يا فندم.
طيب خلاص كده 100
كده
100
ممتاز.
كده هايل.
تمام التمام.
كده احسن يا فندم.
خلاص احنا ما عندناش مشكلة خالص.
كده الصوت والصورة منورين يا فندم.
يا باشا لا، اللي منورين هي صوركم انتوا بصراحة.
ربنا يخليك دكتور خميس، ربنا يخليك.
والزعيم اللي في وسطكم ده.
الزعيم محمد الاشهر.
لا العفو يا باشا، لا العفو يا باشا. وي ار ريدي يا دكتور خميس، نبدا.
ريدي، يلا يا داليا.
اتفضل دكتور محمد، يلا.
بسم الله الرحمن الرحيم. It's a great honor to be with you tonight in this very scientific session about Talipes Equino-varus from A to Z. Meet the experts. Tonight we have a great collection of superstars from pediatric orthopedic surgeons from all over Egyptian universities. Our first talk will be with the godfather of pediatric orthopedic in Egypt, Professor Khamis Eldeeb, Professor of Orthopedic Surgery, Alexandria University, will speak about the pathoanatomy of Talipes Equino-varus. Dr. Khamis, you are ready, sir?
Sir. Bismillah ar-Rahman ar-Rahim. Dear friends, colleagues, brothers, sons, ladies and gentlemen. داليا.
الشيرنج ما اشتغلش يا دكتور خميس.
ثانية واحدة.
حضرتك شغل الباوربوينت الأول بعدين اعمل الشيرنج.
هي كده باينة يا ابو؟
انتوا سامعيني دلوقتي؟
سامعين سعادتك
احنا
يا فندم.
سامعين.
وشايفيني؟
لسه الباوربوينت ما اشتغلش.
الباوربوينت ما اشتغلش.
حضرتك اخرج من الشير، شغل الباوربوينت وارجع تاني.
حاضر، ثانية واحدة. هي دي Pathoanatomy. ثانية واحدة.
تمام يا فندم.
تمام، فول سكرين بقى لو تكرمت.
فول سكرين.
كده فول سكرين.
كده فول سكرين.
اتفضل يا فندم.
ممتاز، اتفضل.
طيب تمام، اوكي. بسم الله الرحمن الرحيم. Dear friends, colleagues, brothers, sons, ladies and gentlemen. السلام عليكم ورحمة الله وبركاته. First, I would like to thank Banha Orthopedic Department for kinding me to share in this elegant scientific gathering. And thanks again for giving me the honor and privilege of lecturing to the colleagues whom I didn't see actually, but I feel that my heart is knowing them very well. Before we start this talk, I would like to remember this great man, one of the most influential spine surgeons in Egypt, that is Professor Abdel Mohsen Arafa, who passed away some 12 weeks ago. Please, I need a minute of silence, not silence, just to read the opening surah of our Holy Quran, على روح الطاهرة وندعو له بالرحمة والمغفرة. Okay, this is Al Hadra University Hospital, the biggest orthopedic and traumatology in Egypt and maybe in the Middle East. 500 beds, orthopedic beds, I mean. And this is Alexandria, my beloved city. This is the Stanley Bridge. زي ما احنا بنحب اسكندرية، الحبيبة بيتقابلوا هنا ويتمشوا على الكوبري ده، مكان كويس للتمشيط الحبيبة يعني. This is the Roman Amphitheater، المسرح الروماني في العطارين عندنا في اسكندرية، اكتشفوه سنة 69. دي مكتبة اسكندرية. This is the Alexandria New Library. And the subject of my first talk is pathological anatomy of congenital clubfoot. This is a bilateral clubfoot in a 90 millimeter male. يعني 10 يعني 9 سنتي. يعني وكان ده 17 weeks old fetus. The problem of pathoanatomy of clubfoot is this. Which came first? هل هي البيضة ولا الفرخة? The egg or the chicken? In clubfoot, which came first? Is it the talar head dislocation or subluxation or the posteromedial soft tissue contractures that led to this? دي اللي شغلت يعني تفكير الناس وكان حصل نقاشات ودراسات كتيرة عليها. The abnormal anatomy of congenital Talipes Equino-varus was first described by Antonio Scarpa in 1803. 1803. The description was medial displacement and inversion of the navicular, cuboid, and calcaneum in relation to the talus. The anomalies of the muscles, tendons, and ligaments of the foot and leg are secondary to this skeletal deformity. يعني معناها الجوينتس dislocated وده اللي عمل الكلام. يعني الأول الفرخة مش البيضة يعني. William Adam in 1973 in his very famous book Clubfoot, Its Causes, Pathology and Treatment, described the pathology of 30 club feet and believed that the main anomaly resides in هيقول ايه? Medial and plantar deflection of the head and neck of the talus, which is mainly an adaptation to the altered position of the oscalcis and navicular, still accusing the bones. Following these two classic works, some 40 scientifically reliable studies based on anatomical studies of club feet in fetuses, untreated stillborn, and in deceased infants were published. دي أسامي بعض منهم من المشهورين. مثلا مايكل هاورد بنسون وموسمان، يعني دول ناس يعني معروفين بره بس مش احنا ما بنعرفهمش كويس يعني. Since 1947, Ignacio Ponseti studied serial histological sections of 12 club feet and 4 normal feet of fetuses with unilateral deformities and feet with bilateral deformities. All the fetuses were aborted at 16 to 24 weeks of gestation. Ponseti also studied anatomical dissections of 3 club feet of stillborn babies and 3 club feet recovered from 2 full-term babies dead shortly after birth. One had bilateral club feet and one had unilateral deformity. In these cases, there was no oligohydramnios, there is no pressure over the bones, and also normal neurological data, including the brain and spinal cord. No neurological problem. These are the findings of Ignacio Ponseti. The first part is about the bones. The navicular was medially displaced and its tuberosity was very close to the medial malleolus. This is the navicular and this is the medial malleolus. Again, the navicular and the medial malleolus. Here, the tendon of the tibialis posterior was found to be very thick. This is the first observation that mentioning something related to the soft tissues. The tibionavicular and calcaneonavicular ligaments were very thick, short, and very cellular. Deep layer of the deltoid ligament was thick and appeared to have been pulled into the joint between the medial malleolus and the talus. You see this clearly. The talocalcanean interosseous ligament was thin, formed of strands of collagen fibers and nearly devoid of cells. The talus was in severe flexion, body is small, altered in shape, and trochlear height was decreased. In severe cases, the talus was inverted in the ankle mortis. Talar neck medially and plantarly deflected. Head of the talus was covered by articular cartilage of the navicular in its medial aspect only. The navicular was uniformly flattened or laterally wedged and severely medially displaced, adducted, and inverted. The medial tuberosity was large of the navicular, of course, and close to the medial malleolus, as you see in this cut section. The calcaneus, the body of the calcaneus was in severe flexion, slightly medially bowed, and in some cases it seemed longer than the normal side. The calcaneus was adducted and inverted underneath the talus. Most of the anterior tuberosity was under the talar head and not lateral to it as in normal feet. The longitudinal axes of the talus and calcaneus were parallel. They should be diverted. The cuboid was medially displaced and inverted in front of the calcaneus. Only the medial part of the anterior tuberosity of the calcaneus articulated with the cuboid. The talocalcanean articulations were abnormal, as you see in this cut section. The cuneiforms and metatarsals were always adducted, but were normal in shape. Tibialis anterior and extensor hallucis were severely medially displaced. Ligaments of the inferior tibiofibular syndesmosis were thick. Let us come to the second part, which is the most important part. Structural changes in the muscles, tendons, vessels, and ligaments of the leg and foot. Muscles. Triceps shuri, tibialis posterior are smaller and shorter. Muscles of the anterior and medial compartment of the leg were smaller in girth than controls. Muscle size correlated inversely with the severity of the deformity. The peronei were normal. This is the triceps shuri. This one is on the left is in the diseased leg, and this is the normal. See how much the triceps shuri is smaller. As for the fasciae, the superficial and deep fascia of the calf were thick in the lower part of the leg. Abnormality in the fascia also, especially in the lower part of the leg. Bundles, look at this sentence, bundles of connective tissue fibers from the deep fascia penetrated into the muscles. Calf biopsy studies using electron microscopy showed a considerable amount of connective tissue between muscle fibers, especially in young patients. Tibialis posterior tendon, distal part is thickened 2 to 3 times. Sheath was thickened and matted to the ligaments. Tendo Achilles inserted more medially in the os calcis. Ligaments of the posterior and medial aspects of the ankle and tarsal joints were very thick, taut, and firmly restrain the foot in equinus. The navicular and calcaneus in adduction and inversion. Other tight structures are the calcaneofibular ligament, superior peroneal retinaculum, and posterior talocalcaneal ligaments. Zimny and associates in 1985 observed in histological sections of ligaments fibroblasts with cytoplasmic microfilaments, myofibroblast-like cells, and mast cells in the medial side of the foot ligaments only. None was found in the ligaments of the lateral side. So there is a problem here in the ligaments and muscles on the medial side. The findings of Zimny and associates goes with the hypothesis that a retracting fibrosis is the primary etiological factor of the clubfoot deformity. This is the end result of Zimny and also our friends Ippolito and Ponseti. So the problem is mainly in the soft tissues, and bony deformities are secondary to the soft tissue problem. Accessory or absent tendons or muscles, tibialis posterior accessory muscle was sometimes sometimes its complete absence may be encountered. I have seen only once. Connecting tendon between the tib ant and the tib post was rarely encountered. I haven't seen it. This is the accessory tendon. Vascular changes. Several studies using angiography and Doppler technique have shown absence of the dorsalis pedis artery, which ranged from 7 to 85% in our cases. This should be taken into consideration when extensive posteromedial release was carried out, especially in older children. But I think the problem is not in this, but the problem is the type of surgeon that's going to operate upon these cases. Summary of the structural changes. Bony changes, the involved leg and clubfoot may be short, and so also the femur. The size of the foot is smaller. Many of the foot bones are deformed, especially the talus, short neck, medial and plantar deviation. Ankle joint talus is in equinus. Head talus points medially, anteriorly subluxated. Calcaneus moves posteriorly to lie beneath the talus and not lateral to it. The talonavicular joint, the navicular lies on the medial side of the head of the talus. Look at this cut section showing these deformities that I just mentioned. Tarsometatarsal joints also, we are having shortening of the short and leg plantar ligaments together with the plantar fascia will produce flexion at the tarsometatarsal joints leading to cavus. Calf muscles is wasted in proportion to the severity of the condition. It also shows different degrees of fiber abnormality, as I mentioned before. Fibrosis is marked in the triceps shuri, tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Reduced muscle excursion, apparent overaction of the tibialis anterior due to reduced excursion. Peronei are elongated and partially weak. better understanding of these pathoanatomical facts led our hero Ignacio Ponseti to introduce his unique method of manipulation and casting in the treatment of clubfoot deformity with incredible success, reaching up to normal, or let me say, near normal feet. I think Professor Hisham Elghany is going to clarify everything about the Ponseti technique. At the end, we need a foot like this. I think we can succeed to do it, mostly by conservative means, sometimes by surgical means. Thank you very much.
Thank you so much, sir, for this very informative and illustrative talk about the pathoanatomy of Talipes Equino-varus. Now we will move to the second talk of Professor Hisham Elghany, Cairo University, and one of the eminent stars of pediatric orthopedics in Egypt and all over the world. We'll speak about principles of Ponseti technique. Thank you for joining us, Professor Hisham.
بسم الله الرحمن الرحيم. شكر لحضرتك والدكتور محمد الأشهب والدكتور أحمد علام for organizing such a wonderful meeting. Really, it's an honor for me to be part of this group of lecture. My talk is about Ponseti technique. To understand Ponseti technique now is the leading method for treatment of clubfoot. من 20 سنة فاتوا أي حد عصر الفترة دي هيكتشف إن الكلابفوت تقريبا ما فيش حاجة أبدا زيها حصل فيها marked change in the line of treatment زي ما حصل في الكلابفوت الحقيقة يعني dramatic change. To describe the clinical picture of clubfoot and the method of treatment, the Ponseti method for treatment, we have to remember this acronym, CAVE. This describes the clinical picture and describe also the method of treatment. CAVE, C stands for cavus. All the club feet has a cavus deformity with drop of the metatarsals in relation to the hind foot. But there is an extra drop on the first ray more than the other ray. And this is very important point to be pointed because this produces pronation of the forefoot in relation to the hind foot. The club foot is a totally supinated foot. The sole is facing inward, but the forefoot is pronated in relation to the hind foot, and this is due to the excessive drop of the first ray in comparison to the other rays. This is the C. A means adduction of the forefoot in relation to the hind foot. There is adductus element. And V stands for varus. The heel is in varus. The subtalar joint is in varus. And of course, E stands for equinus, which is a very crucial point for diagnosing clubfoot. This is a case for the first look, it is a clubfoot, but once you are able to produce or stretch or achieve full dorsiflexion of the ankle, this is not a real clubfoot. This is a postural clubfoot. This does not need treatment. It will correct spontaneously. So equinus is a crucial element for diagnosing clubfoot. And of course, we have to know the site of the talar head because all our manipulation will be around the talar head. The talar head is about 1 centimeter anterior to and distal to the lateral, the prominent lateral malleus. So the Ponseti technique, why it is successful? Because it took advantage of the real biomechanics of the foot. What we want to know is that the whole foot move as a one segment. It's a guided movement. It's a very complex 3D movement. There is no single joint move in isolation or moves together. And the forefoot moves with the calcaneus in what's called calcaneopedis block. And the bones of the forefoot with the metatarsal bones, and the calcaneus form what's called acetabulum pedis. And the head inside this acetabulum is the talar head. But in the hip, the head moves inside the acetabulum, but in the foot, the acetabulum moves around the head. So if we did forefoot abduction, the calcaneus invert and extend. And if we did forefoot adduction, the calcaneus invert and flex. If any one of us try it on himself or any other normal subject, if we do adduction of the forefoot, the heel will goes into varus. And if we do abduction of the forefoot, the heel goes into valgus. That's mean I can control and guide the movement of the heel without touching the heel, with just manipulation of the forefoot, provided that this manipulation occur around the talar head. So if I fix the talar head and do forefoot abduction, I will guide the calcaneus into valgus without touching the calcaneus or without directly manipulating the calcaneus. So the subtalar joint movements are kinematically coupled, and the movement occur in several different directions at the same time. And the Ponseti technique works because it takes advantage of the proper understanding of the biomechanics of the foot. So if we look at the clubfoot, we can imagine it as a foot in extreme supination, in extreme inversion of the subtalar joints, which means the forefoot should be adducted, the heel should be in varus, and the whole foot will goes into equinus. The technique of the Ponseti technique is not just a manipulation to correct the foot. No, it's a specific method of manipulation, okay? But at the same time, it may be followed by percutaneous tenotomies in the vast majority of cases, and long-term bracing is a part of the Ponseti technique for a successful outcome. So the correction will go, as we said before, following the acronym cave. First, we have to correct the cavus, followed by adductus and varus, and then lastly, equinus. How to correct the cavus? By elevation of the first ray. So first, we have to correct the pronated forefoot in relation to the hind foot. So actually, we are increasing the supination of the whole foot. As I told you before, the whole foot is supinated, but the forefoot is pronated in relation to the hind foot. So the first step is elevation of the first ray to correct the excessive drop of the first ray, and this will increase the total supination of the foot. In all our manipulation and the Ponseti technique, we have to fix, and we have a finger at the talar head to fix the talar head to allow the whole movement of the calcaneopedis block around the head, which is the talar head. This is the original photos of Ponseti. This explained in a model. So we do first elevation of the first ray and then gradual abduction, progressive abduction. And this abduction will correct the position of the hind foot and the calcaneus automatically without touching the calcaneus, without manipulating the calcaneus directly, because we understand well that the forefoot movement is coupled with the hind foot movement around the talar head. Then we do cast. First cast, the foot is supinated with excessive supination because we elevated the first ray. And then in sequential casting, we do gradual abduction of the forefoot, but still the foot in equinus. The question is, how frequently is the casts? And what are the number of the casts? Usually, the cast is done every week. There is an accelerated protocol described by Shafi Pirani every 3 days. But in the majority of cases, we don't need this accelerated protocol every week. There is nothing called every 2 weeks or every month. There is nothing called we do cast now and we have to take a rest for another week and then do cast again. We hear all of this. we hear all of these mistakes. Every week, the cast has to be removed, a new cast, and the new cast is done immediately at the same time. If you left the foot for a while or a few hours or a day, the foot will swell, and this will make application of the new cast difficult and make the cast loose. So at the time of removal, the new application is done. In the majority of cases, usually the casts are not more than 6 casts. Everyone may have his experience, but in the majority of cases usually take about 4 casts only, including the cast of tenotomy, but it could be extended to 6 casts. For beginners, it may be more than this, but if you are continuing to do a lot, many casts, then you are doing something wrong. The padding should be minimal to control the foot, and we have to avoid excessive padding, because excessive padding will not allow you to manipulate and the key position of the foot and to mold the cast properly. The classic material to be used is the plaster of Paris. But in my hand, I use the fiberglass cast. I don't have problem with the fiberglass cast, but it is not wrong. You can do whatever you like, but you have to stick to the proper manipulation and to proper molding. The molding is very important. We have to leave a mark here, fixing the head of talus, and also we have to do an indentation on above the heel here to avoid and prevent slipping of the heel inside the cast. The cast should be above the knee, and as I told you, in progressive and sequential casting, after the first one, we do sequential gradual abduction of the forefoot without touching the heel, and this abduction will control the position of the heel. Tenotomy is needed, and it is an integral part of the Ponseti technique in more than 90% of cases. It's very easy to be deceived that this foot does not need tenotomy. But with gaining experience, the instance or the need for tenotomy, the percentage of needs for tenotomy increase with expert surgeons, and it is low in less experienced surgeons. The prerequisites for tenotomy, the heel should be in neutral or in valgus, and we can achieve about 70-degree external rotation of the forefoot. This is the appearance of the calcaneus before tenotomy. It is in equinus, and after tenotomy, it dorsiflex, and the ankle get dorsiflexion. This is the preoperative and the post-operative. Tenotomy could be done by scalpel. The scalpel should be inserted medial to the tendon Achilles and then rotated, and the blade come to face the skin posteriorly, and then do dorsiflexion, and it will pop up. We should do the tenotomy about 1 centimeter proximal to its insertion, because it becomes narrow and easy to cut. We shouldn't do it at the insertion to the calcaneus, because at this side it is broad and difficult to get it completely. I do it with a needle, a thick needle, 14 gauge. It is done in the same method, but usually it needs some sequential cutting by the tip of the needle. I use the tip of the needle as a scalpel, and this does not leave a scar and does not leave the scar of the classic incision done by the scalpel. The last cast usually lasts from 2 to 3 weeks, and after that, after removal of the cast, then we have to shift to the retention treatment or the bracing. A point I want to elaborate on it: when to start Ponseti technique. If you have a newborn 1 day old, when you start Ponseti technique. Now, it is advisable to start Ponseti technique from 1 to 2 weeks, and better to be at 2 weeks. Because in very young neonates, the foot is very small, there is vascular liability, and it's easy to get the toes blue because the autonomic nervous system is not well developed at this age. And most surgeons all over the world now prefer doing it from 10 to 14 days of birth. And the historical statement that we have to start treatment of the clubfoot intrauterine, even if we could, is not so true now. The bracing is to use the abduction foot brace. It is the Dennis Brown brace, or whatever you call it. You can use EFOS on the Dennis Brown, or you can use medical shoe. And the diseased foot should be kept on 70-degree abduction, and the normal one should be kept at 45-degree abduction. This brace should have a pent like that, or a dorsiflexion at the level of the EFO or the foot to keep stretching the tendon Achilles. After removal of the cast, and we have to stick to this brace program because recurrence in the majority of cases is secondary to non-proper bracing technique, and not the type of the brace. If you use the Ponseti original brace, whatever the brace, the Shafiq Birani in brace in Uganda using كان بيستعمل حديد مسلح يعني عشان يعمل البريس, all are effective so long they are keeping the feet in the proper external rotation position. In the first 3 to 6 months, it should be done, it should be weared for about 23 hours per day, and later on should continue at night time from 10 to 12 hours per day to the age of 3 to 4 years. And we have to teach the mother to do some manipulation of the foot, like stimulation of the lateral border of the foot, dorsiflexion and the plantar flexion and the external rotation exercise during time of removal of the brace. What actually happened to these bones when we are doing this manipulation? Shafiq Birani did a very nice study, did an MRI study for the feet during correction, during week 1, week 2, and up to week 5, and then after tenotomy. And he took cuts in the MRI, one cut perpendicular to the talonavicular joint, another one perpendicular to the ankle joint, one at perpendicular to the subtalar joint, and the last one at the cut perpendicular to the calcaneocupoid joint. During week 1, look at the talonavicular joint. The navicular is displaced, severely displaced medially, and it is triangular. But in week 3 and week 4, look, the talus shape change, and the navicular shape change, and it acquire its trapezoid appearance and trapezoid shape, and it reduce in position. But all these changes are in the cartilage, but the ossific nucleus are the same. So it produced not only reduction of the joints, but change in the shape of the cartilaginous mold of the bones. The calcaneocupoid, the cuboid is displaced medially, and the distal articular surface of the cuboid is oblique. At the end of manipulation, look, the cuboid is in place, and the calcaneum articular surface become perpendicular to the calcaneum. The subtalar joint in varus at the start, and then become in valgus, and the shape of the calcaneus itself change. And lastly, the dorsiflexion of the ankle occur only after tenotomy and not before. So it is not, this manipulation technique is not just changing the position of the joint, but changing the shape of the bones itself. What are the mistakes that could be done? It's said that it took the word about 50 years to move the finger 4 centimeters instead of the fixing the anterior process of the calcaneus, it shifts to fix the talus. This is the kite mistake. And from understanding the proper biomechanics, this is absolutely wrong. We are doing dissociation of the calcaneopedis block. Also, pronation of the forefoot. This is increasing the cavus, not correcting the foot, really. Also, if we didn't fix the talus and we did the external rotation without fixing the talus, this will produce external rotation at the level of the ankle mortise and posterior subluxation dislocation of the fibula posteriorly. There is nothing called Belloni cast. Belloni cast cannot control the position and the external rotation of the foot. Bad casting technique is a very important mistake that has to be kept in mind with improper molding and excessive padding. A cast like this will never be able to correct clubfoot. Just to reminder, no place for what's called adhesive plaster tape now for treatment of club feet in this area. يعني مش عارف بس صعب قوي لحد دلوقتي نشوف ان بيتعمل plaster taping for adhesive taping for club feet. No rule for such technique whatsoever. One of the commonest mistakes is the missing short tender Achilles, because after correction, the subtalar joint, the mid-tarsal joint becomes supple, and you can achieve very good dorsiflexion, but not at the level of the ankle. It is at the level of the mid-tarsal joint. So to test the tender Achilles shortening, we have to supinate the foot. But keeping the foot fully corrected and then testing dorsiflexion, we are doing the dorsiflexion at the level of the mid-tarsal joint, and we can very easily miss short tender Achilles. One of the commonest mistakes is improper follow-up. Short-term bracing, stopping bracing very early before the age of 3 or 4 years. Using FO, ankle foot orthosis, instead of abduction foot brace. They do nothing. Use of medical shoes. Really, I searched a lot. There is nothing called medical shoe for treatment of idiopathic classic club feet. Medical shoe may have an application in some cases of arthrogrypotic, paralytic club feet, but not for the idiopathic club feet. They have nothing to do for prevention of recurrence, for keeping the foot corrected. They are cumbersome, deprive the foot of proprioceptive sensation, and there is no rule for them. So, in many researches, they found that the pathological change that provoke the clubfoot seems to persist during the first 4 years of life. That's why we have to keep the foot braced for the first 4 years of life. We may use the above knee abduction foot brace, but its manufacture in Egypt is very difficult, as there is no proper publication giving it a credit like what has been published about the Dennis Brown technique. So in about 6 weeks, we can correct a very difficult problem with about 75% success rate. This is an example of a case after correction, and here the child is walking. In the earlier age, the aim of correction of clubfoot was a plantigrade painless foot, but after Ponseti, the aim is to achieve almost a normal foot. This is another child, and this is after correction, and this is after 10 years of age. So treatment of clubfoot, as will Dr. Khamis will tell you, is manipulation, 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 and then come any other technique other than manipulation. And the manipulation and choice is the Ponseti technique. Thank you so much.
Thank you so much, Professor Hisham, for this very interesting talk, clarifying the Ponseti technique. It makes it very obvious for each of us. Thank you so much. Before going back to Professor Khamis, we have one question for you, Professor Hisham, from Dr. Iyas Zakoli. Do you recommend serial stretching before starting Ponseti for newborn until 2 weeks of age, sir?
No, no. Usually we start casting. I do it after the 10 or 14 days age, not before. And I don't ask the mother to do anything for the food in advance.
Thank you so much, sir. Now, again, with our beloved Professor Khamis Eldeeb, Professor Khamis will speak about surgical management of clubfoot.
بسم الله الرحمن الرحيم. قبل ما ابدا التوك بتاعي على السيرجري كلاب فوت، يعني بشكر الدكتور هشام بيه على الدقه الشديده في عرض البونسيتي تكنيك. يعني لا بجد والله، يعني احنا انا دايما بسعد لما اكون معاك يا هشام، لانك انت very clear and very convincing الحقيقه. يعني
الله يخليك.
هو طبعا انت قلت كلمه مهمه، ان التريتمنت اوف كلاب فوت مش جراحه خالص. الجراحه كومبلمنتري بعد ما تنجح انت انك تعمل المانيبيوليشن الصح وتعمل تينوتومي للتنتو اكيلس. هي دي ما دي جراحه، لكن مش تعالج جراحه من اول يوم. اوكي، نقول بسم الله الرحمن الرحيم. اولا السلام عليكم ورحمة الله وبركاته. بنبدأ بالبروفيرب ده. It is nice to see good things happen to someone so deserving. This is the someone who is deserving congratulations. In the name of myself and on behalf of the pediatric orthopedic surgeons in Egypt, I would like to congratulate Professor Gamal Ahmed Hosny, President of the Egyptian Orthopedic Associations, for being chosen as specialty editor of the Journal of Pediatric Orthopedics European part. This is the Journal of Pediatric Orthopedics, and this is Gamal Hosny, Banha University Hospital, Cairo, Egypt. This is the logo of the Egyptian Pediatric Orthopedic Society, which we used for some time. And this is my picture when I was in Saudi Arabia, and for the first time I gave this lecture in one of the congresses in Saudi Arabia, actually. Again, Al-Hadra University Hospital. And actually we started the project of pediatric orthopedics in 1974. This is the title of the papers that we published in 2007 in the Journal of Pediatric Orthopedics. I don't know whether if the Gamal is there, he would accept this paper or not, but it was accepted 1 month after sending the paper to the Journal of Pediatric Orthopedics. This is the team, Professor Abdul Sabur Hunaim, Professor Khalid Al-Adwar, Ali Khalil, the candidate, and myself. This is the first page of the paper. Is it hazardous or mandatory to release the talocalcaneal interosseous ligament in clubfoot surgery? Recalling again this word, Hisham, treatment of clubfoot, conservative treatment by manipulation and casting is the rule. Surgical treatment is the exception. So the golden rules in treatment of clubfoot are: the earlier the treatment, the better will be the end results. Non-operative treatment should be started initially to correct all components of the deformity. واعتقد بروفيسور هشام كان واضح قوي المشكله بتاعت كايت قبل كده وبونسيتي، ان الهيل should not be manipulated. We manipulate the fore and mid foot and the heel will come with trial to move the subtalar and telenavicular اللي هو اسمها calcaneopedis block اللي هي المبدأ بتاع إغناسيو بونسيتي. The conservative treatment اللي كان موجود قبل بونسيتي هو أول حاجة يعني الناحية ديت دول كانوا 3 حاجات في العالم يعني معظم العالم كان بيشتغل على manipulation and casting اللي بداها كايت سنة 39 لكن برضو كان فيه مشكلة في المانيبيوليشن بتاعته. كان 2 في فرنسا بيشتغلوا شغل تاني. الأولاني هنري بن ساهل، وهنري بن ساهل ده كان بيخلي بتوع العلاج الطبيعي وهم اللي يعملوا مانيبيوليشن. وبعدين ديميليو في يعني الراجل ده عمل حاجة ظريفة، عمل CPM ماشين في مونبلييه. بس الحقيقة these 2 methods didn't gain international acceptance وفضلت sear manipulation and casting again in the way of Ponseti هي الأساس. ده ألين ديميليو وده هنري بن ساهل. يعني بعيد تاني شوية كلام من كلام هشام لأن دول الأساس في العلاج بنذكر بيها وذكر في أن الذكرى تنفع المؤمنين. This is the technique used most frequently. It requires training and experience. هشام وضح الكلام ده كويس جدا وأكد على حاجات مهمة قوي قوي قوي. إذا ما عملناهاش يبقى ما عملناش حاجة. Poor technique can result in failure of treatment and can create complications. اللي هشام قالها ان انا اقعد اعمل manipulation بطريقه غلط هيحصل ايه؟ هيحصل روكر بوتوم ديفورميتي على طول. It should be as early as possible to utilize viscoelastic character of the newborn foot and resistance to atrophy and stiffness from immobilization. وبرضه هشام وضح لنا 2 weeks after birth. manipulation and casting اللي بيتكلم على كايت برضه احنا مش هنشتم في الراجل، هو الراجل توفاه الله وكان بيصلح كل حاجه في الاول. يقعد الادكشن الاول وبعدين الانفيرشن وبعدين التندو اكيليس برضه يعمل مانيبيوليشن وكان بيصلح من الهيل. جاء كان كلمته المشهوره he was adamant to say that one should not proceed to correct the next deformity unless the previous one had been corrected. عكس اللي قاله بونسيتي خالص. ده جوزيف كايت. بونسيتي طبعا مش هتكلم تاني عليه لان هو طبعا وضحه هشام بدقه شديده. وبرده التندو اكيليس تينوتومي اللي هو اصر عليها. هضيف بس حاجه صغيره ان بونسيتي مره كان في محاضره اتكلم وقال sometimes we need to do tibialis anterior transfer which may be needed if everything is corrected but there is dynamic bars. That's why he do tibialis anterior transplant in case of dynamic bars. على فكرة دي البالياريك ايلاندز اللي هي جزر البليار. عمنا إغناسيو بونسيتي اتولد في مينوركا ديت اللي هي البلد بتاعتها اسمها سيوتاديلا ودي مش الجزيرة الكبيرة. وقابلته هناك سنة 2005 في بالما دي مايوركا والراجل مشكور أهدى لي كتابه وما رضاش ياخد مني فلوس يعني. Ponseti passed away in 2009 وده كتابه وإهداؤه مشكور بخط إيده. هو راجل كان عايش أساساً في أيوا سيتي في أمريكا. في بقى الكلام اللي كان بيتقال قبل كده قبل ما يجي بونسيتي وغير المفاهيم. كان في مجموعة من الأطباء العظام يقولوا conservative treatment in the uncorrected or partially corrected feet is unlikely to succeed. كان الزعيم بتاعهم تومسون 3 شهور لا خش في العمليات على طول، عكس اللي بيقولوا بونسيتي واللي قاله هشام وأكده يعني. Ponseti believes that he can start his manipulation. ده كلام ده سمعته منه شخصيا ومن شفيق براني بعد كده. as late as 4 to 6 years of age with considerable success. معلش انا مش مقتنع قوي، ويمكن يحصل بيني وبين هشام خناقه في اخر التوك ده عشان نشوف الكلام اللي قاله ده هل هشام مقتنع بيه ولا لا. يعني بعد 6 سنين اقعد اعمل manipulation it's very difficult. What are the goals of surgery? Is to obtain cosmetically acceptable, pliable, plantigrade foot and to avoid triple fusion in older age. يعني we need a foot like this زي ما قلت قبل كده. الكونسبت in early surgical release كان الآتي. كان في مدرسة بتعمل restricted release. They are releasing only the structures that are thought to be the most apparent cause of resistance. وكان الزعماء بتوعها محترمين قوي، شارد وبن ساهل وبونسيتي وكاترال. الجماعة التانيين المجموعة الأخرى بتقول لا، complete release should be done. All components of the deformity be released simultaneously including the TCIL, talocalcaneal interosseous ligament. وطبعا أشهر واحد كان بيأيد الكلام ده هو فينسنت تيركو في أمريكا. الإخوة بتوع الريستريكتد ريليس كانوا بيقولوا إيه؟ إحنا بنعمل ليه ريستريكتد ريليس؟ Because complete release often results in stiffness, a vascular necrosis of the talus and the navicular, and the functional results are poor. الجماعة بتوع الكومبليت ريليس بزعامة تيركو طبعا قالوا these complications do not occur and long-term results are good. يورينا حالات. ده فينسنت تيركو طبعا he passed away in 1999. طب هنصدق مين ولا مين؟ جبنا كتاب جميل جدا كان عمله واحد اسمه جوزيف ترويتا، هو على فكرة اسباني راخر وكان مولود في برشلونة، ونقلت لكم منه بعض الكلام على التيلس. ليه التيلس يجي لها فاسكولار نيكروزس؟ عشان احنا قطعنا التيلوكالكينال انتروسس ليجمنت. فعشان كده هنعمل حاجه نبص على الاستادي بتاع الفاسكولار سبلاي اوف ذا تيلس اللي موجوده في كتاب جوزيف ترويتا اللي هو Studies of the Development and Decay of the Human Frame. بيقول حضرته ان التيلس has no muscle attachment, no tendon insertions, 2/3 of the body is covered by articular cartilage. Most of the vascular supply is from vessels piercing the neck and tarsal canal. دي برشلونة طبعا اهيت اللي اتولد فيها جوزيف ترويتا، و بتفكرنا بزمان برشلونة ونادي برشلونة واتلتيكو بلباو وريال مدريد والحاجات الظريفة دي. يعني شايفين قد ايه very close to France and to Italy يعني. دي بالما دي مايوركا اهي وبرشلونة فوق خالص في الحتة الفوقانية ديت، ودي جزر البليار مرة تانية. ده جوزيف ترويتا he passed away in 1977 وده الكتاب بتاعه Studies of the Development and Decay of the Human Frame. أنا اشتريته سنة 74 بكام بقى تفتكروا؟ ب 30 يورو، مش يورو بقى، 30 استرليني، لأنه مطبوع في إنجلترا. يعني كان تقريبا مرتبط شهرين الثمن البتاع ده. جوزيف ترويتا is originally a Spanish citizen، واسمه في الاسباني كان جوزيب ترويتا راسبال، معاه MD في RCS في ACS، Professor of Orthopedics University of Oxford, member of the following associations: American Academy of Orthopedic Surgeons, British Orthopedic Association (SICO), and other associations in Canada, Germany, Scandinavia, Italy, Brazil, Colombia, and Spain. دي أوكسفورد اللي هو اشتغل فيها طبعا. وده اسم الكتاب، وكان first published in 1968. الطبعة اللي عندي كانت في السنة ديت. وشابتر على circulation in the bone chapter 21، كتاب محترم يعني وضخم. وكان الصفحتين دول 52 و 53 على الفاسكولار سبلاي فاسكولار باترن اوف ذا تيلس. هوريكم بعض سلايدز منه. بيقول جوزيف ترويتا ان التيلس فاسكولار vascular supply of the talus is very, very, very rich. And the talus lies at the center of a large interconnected vascular network supplied by the three main arteries of the leg: anterior tibial, posterior tibial, and peroneal. Within the bone, there is an extensive communication, anastomosis, between all sources of the blood supply. ده واضح الارتري of the tarsal canal، وادي اللي فوق ده هو الدلتويد ارتري، وادي ورا برضو بعض البلاد فيسلز من البيرونيال ارتري داخلين في البوستيريور تيوبركل اوف ذا تيلس. هو عد البرانشز اللي موجوده اللي ظهرت في الانجكشن ستادي، لا الانتيريور تيبيال بيدي 6 برانشز. 4 of them pierce the neck and 2 only pass in the sinister side. البيرونيال في 2 جروبس بس، one pass in the posterior tubercle and the other is in the sinister side. نيجي posterior tibial اللي هو المين سبلاي بقى 3 جروبس. Group pass in the posterior tubercle and artery of the tarsal canal and deltoid artery that supply the neck and medial third of the body of the talus. طبعا الكوميونيكيشن ده بيعوض اي حاجه ممكن تحصل. دي برضو صوره ثانيه للفاسكولار سبلاي اوف ذا talus، وادي شكل الدلتويد ارتري، وادي الارتري اوف ذا تارسال كانال. بيقول كرويتا بيقول it is only 4 out of 11 arteries pass in the sinister side that are liable to be compromised by the release of the TCIL, talocalcaneal interosseous ligament. So the clinical implication of talar vasculature, deprivation of a single source of the arterial supply generally does not cause an AVN except perhaps a small localized area. ثبت بالانجكشن ستادي بتاعه، بس ما فيش كلينيكال ستادي اتعملت عشان نشوف الكلام ده صح ولا غلط. شفيق بيراني عمل MRI عشان يوري الديفورميتي كوركشن. احنا في اسكندريه عملنا MRI بعد ما عملنا ريليس لسوفت تيشو ريليس ل 33 حاله with release of the TCIL و30 من غير ريليس. عملنا كل حاجه ما عدا ال TCIL ريليس. The aim of our study actually was to evaluate the results of terco-postropedial release with and without release of the talocalcaneal interosseous ligament. مش هنعيد الكلام ده مرة تانية، نخليها TCIL وخلاص. In the treatment of clubfoot between the ages of 3 months and 2 years. 66 feet in 46 patients were operated upon at El Hadra University Hospital from 1998 to 2001, age 3 to 24 months, highest incidence 6 to 12 months. Most of the cases were between 6 months and 12 months. 41 males and 5 females. Most of the cases were bilateral, 20 bilateral. Follow-up 9 to 10.5 years, so 9.9 years average. Pre-operative conservative treatment was done before we started surgery, but the results were not that good. Surely they are not doing it in the way that was described by Ponseti and Hisham Elghany. Manipulation and plaster fixation. Of course, a clinical examination first, radiological examination. In plain radiography, we did measure the following angles and indices before and after surgery. يعني كلنا عارفين الانجلز والانديسز دي كلها. الجديد ان احنا عملنا 5 months after surgery MRI to the ankle and foot to assess the vascularity of the talus and navicular and other tarsal bones. سنة 1968 هذا الرجل العظيم أستاذ دكتور حسين حساب كان على علاقة جيدة بواحد اسمه نويل بلوكي، كان رئيس قسم عظام الأطفال في جامعة جلاسكو. فكلمه قال له والله أنا عايز أبعت لك حد من عندي مدرس ياخد تريننج عندك على البيدياتريك أورثوبيدكس. طبعا أدي جلاسكو اهيت، وادي الاستاذ لطفي الادور لما كان شباب قوي سنة 68 وراح 3 سنين قعد في هذه المستشفى المحترمة من 68 ل 71 اللي هي يورك هيل هوسبيتال فور سيك تشيلدرن جلاسجو سكوتلاند يو كي. وكان نويل بلوكي ده صديق الأستاذ حساب، وكان التيم اللي شغال معاه دانكان ماكفيرسون اللي سكند مان، ومايكل سميث والان كونر، والبروفيسور لطفي الادور طبعا كان استاذ، كان زائر معاهم وكان مدرس جراحه عظام في الكليه عندنا. دي صوره دانكان ماكفيرسون مع عندنا في مستشفى قدام مستشفى الحضره، كان سنه 70. وعلى شماله الاستاذ حساب وعلى يمين الاستاذ جواد حماده الكبير اللي هو ابو جواد الصغير. وفي ناس كتير موجودين من ضمنهم انا لابس نظاره وتخين، كان وزني 110 كيلو، بس مش مشكله، نجحنا ان احنا نخس يعني. بروفيسور ادوار returned back home in April 1971 where he established the first pediatric orthopedic unit in Al-Hadra University Hospital. Staff members of the unit were Assistant Professor لطفي الأدور، خميس الديب علي ناجي معيدين، السباعي فرج علي وعبد الصبور ونيم نواب معانا في الوحدة دي. Since that time we started to perform the one-stage complete posteromedial release in congenital clubfoot that Professor Adwar was taught in York Hill Hospital before أخونا العزيز ما يعمل الريليس بتاعه اللي هو فينسنت تيركو بسنة تقريبا. جاء الأستاذ لطفي عمل لنا الحالات دي، وأنا ساعدت دانكان ماكفيرسون في 5 حالات. So we taught this technique from McPherson, the way we do complete posteromedial release. Some other modifications were added by Professor Lotfi Al-Adwar to the original technique of York Hill Hospital. دي البيبر بتاع فينسنت تيركو في ابريل 71. يعني احنا الراجل جالنا وتعلمناها منه قبل 71 طبعا، كان سنه 70. The methods of treatment, it's a modification of Turco posteromedial release زي ما بيعملوها في يورك هيل هوسبيتال. 2 groups, each group is 33 feet. In the first group, group A, we did complete posteromedial release with release of the TCIL. Group B, complete posteromedial release without release of the TCIL. عملنا assessment of the results by a modification of the point system, which is introduced by Simon in 1985, clinical criteria, radiological criteria, assessment, statistical analysis of the case. Technique, we released the following joints: posterior capsule of the ankle, talonavicular, talocalcaneal joint, وبعض الحالات نص الحالات عملنا release of the TCIL وحالات لا. Navicular cuneiform joint and also cuneiform first metatarsal joint. التندون lengthening, tendo Achilles طبعا, tibialis posterior, flexor digitorum longus and flexor hallucis longus. ده الانسيجن اللي بيعملوه في يورك هيل هوسبيتال. نيوروفاسكولار باندل، تندو اكيلس، ده التيبيالس انتيريور اهيت، وادي الاكستنسور ديجيتورم. Z-plasty of the tibialis posterior, and it is exposed here. The muscle below is the digitorum. Exposure of flexor digitorum longus, and again Z-plasty. Release of the talonavicular ligament and release of the abductor hallucis from those calces. دي الجديدة اللي الجماعة بتوع يورك هيل كانوا بيعملوها. السهم ده بيورينا التيبيالس بوستيريور اهيت، وادي المشرط بندخل في الحتة دي وراها على طول ندخل في التالونافيكولار joint. Exposure and release of the cuneiform first metatarsal ورelease of the naviculo-cuneiform joint. يعني دول الاثنين اتعملوا. طبعا التندون الفوقاني ده بتاع التيبيالس بوستيريور. tibialis anterior sorry. وبعدين بعد النافيكولار medial cuneiform نعمل release of the cuneiform first metatarsal joint. تندو اكيليس طبعا زي ما اتفقنا بنعمل له زيت بلاستي. وده we expose the posterior capsule and do tenotomy. We cut the posterior capsule till we see the articular cartilage. In the tunnel in which the flexor hallucis longus lies, we elongated Z-plasty, and in this tunnel we go in at the place of the tunnel. We can put the scalpel and go in the talocalcaneal joint and go straight away anteriorly and posteriorly to complete the posterior release and complete also the talocalcaneal interosseous ligament to be cut at this stage. Subtalar joint, as you see, then suture of the tendons, plaster. Overall results were like this: 61 feet satisfactory and 5 unsatisfactory. This is the general results. In group A, we had 32 feet satisfactory and only 1 foot unsatisfactory. This is the group which we released the talocalcaneal interosseous ligament. Group B, we had 29 feet satisfactory and 4 feet unsatisfactory. Age of the patient, the younger the age, the better the final end results were there. Children aged 1 year or less showed more satisfactory results than older children. Release of the TCIL yielded more satisfactory radiological parameters in group A, especially those associated with hind foot correction, lateral talocalcaneal angle, AP talocalcaneal angle, talocalcaneal index, and calcaneal overlap, talocalcaneal overlap. In both groups, MRI was done. No abnormality of the talar vasculature or any of the foot bones was encountered in the group which we didn't release and in the group which we released. Bilateral clubfoot, we passed rapidly because I took a long time actually, 7 months old. Angles, of course, parallel. Surgery, MRI 5 months, no AVN. Measurement of the angles and indices. 3 years post-surgery. Measurement after 10 years, normal foot. Again, bilateral case, measurement of the indices. Okay, this is the surgery. AVN, no AVN, of course. Measurement of the angle 3 years post-surgery. The shape of the foot. 10 years post. I think it's more than enough to show you a lot of cases here. Conclusions. Kirko complete posteromedial release proved to be a good contribution to the treatment of congenital clubfoot deformity. The age at the time of surgery was an important factor in anticipation of the prognosis, as children aged 1 year or less showed more satisfactory results than those operated upon at older age groups, more than 1 year. Surgical release of the TCIL showed more significant proper hind foot alignment according to the measures, the radiological measures. The idea held by many authors that complete surgical release, especially release of the TCIL, will lead to overcorrection, stiffness, avascular necrosis of the talus is totally incorrect. This has been proved beyond doubt in this study, maybe for the first time, وقال الله شر الغرور, by MRI evaluation. So the take-home message is to go ahead and release the TCIL. Succeed to hit the target as this young boy succeeded to hit the target of the toilet. Shukran, thank you very much.
Thank you so much, our beloved Professor Khamis Eldeeb. I think illustrations اللي حضرتك جبتها والفيجرز بتاعت post-media release makes it very easy for any of us to go with it. Thank you so much, sir.
Thank you so much.
وكالمعتاد طبعا في تحيات خاصة لأستاذنا الدكتور خميس الديب من تلامذته في فلسطين. بيبعتوا لحضرتك تحية خاصة يا فندم.
وسوريا ما بعتتش حاجة النهارده؟
لا سوريا معانا على طول يا فندم، ده كل يوم معانا دكاترة من سوريا كتير جدا يا فندم.
أهلا وسهلا.
ربنا يكرم سيادتك يا فندم.
ميرسي يا بيه.
شكرا يا فندم. دكتور بروفيسور طارق حسن معانا؟
موجود يا دكتور محمد بيه.
اهلا بيك يا فندم. اهلا بيك يا معالي الباشا. منور يا فندم. اهلا وسهلا يا فندم. Now we will go ahead to the talk of the eminent Professor Tarek Hassan from Ain Shams University. Will speak about the unusual complications following treatment of clubfoot. Are you ready, sir?
Yes.
دكتور خميس بيه لسه بنتكلم اهو. الدكتور محمد وائل الصدقه من سوريا بعت لحضرتك تحيه مخصوص. شوف حضرتك بتوع سوريا ما يقدروش ينسوا حضرتك يا دكتور.
لا حبايبي اصلهم
يعني اخواتنا في سوريا كلهم بيحبوا حضرتك يعني.
يا بيه وانا بحبهم اكتر والله.
ربنا يكرم سيادتك يا فندم.
ميرسي يا بيه.
منور يا فندم يا اهلا.
الله يخليك حبيبي.
بروفيسور طارق.
بسم الله الرحمن الرحيم. اولا احب احيي حضرتك يا دكتور محمد واشكرك على دعوتك الكريمه. بحب احيي كل اساتذتي وزمايلي اللي موجودين، وان شاء الله كده اعمل برزنتيشن بسيط. قبل بس ابتدي البرزنتيشن يعني كالعاده دايما بسعد بان انا اسمع المحاضره بتاعت الاستاذ دكتور خميس بيه. يعني محاضرات دايما تبقى شيقه، جاب معايا ميموريز ليورك هيل هوسبيتال في جلاسجو. انا كنت هناك بقى بس في زمن بعد كده. ويعني محاضرات الدكتور خميس جميله جدا علما وموضوعا وهيستوريكالي واتس فيري نايس.
انت عارف ان انا بحبك يا طارق والله. ربنا يعني
مش بزهق يا دكتور خميس ان في كل محاضره اقول ان في لجنه الترقيه من مدرس لاستاذ مساعد حضرتك قلت لي هتبقى محاضر جيد. فالحمد لله انا اعتقد ان انا محاضر مش بطال، بس عشان حضرتك محاضر جيد فكنت يعني انترستد في النقطه دهيت.
انا اكيد هلاقيك جيد ان شاء الله.
ربنا يخلي حضرتك
يا حبيبي.
فانا بس ضعيف شويه في التكنولوجي، فانا هعمل اهو شير سكرين
مع سعادتك يا فندم. اتفضل يا فندم.
شير سكرين وبعد كده اختارها. فادي كده ونعمل البرزنتيشن.
تمام سعادتك. فول سكرين يا استاذنا.
فول سكرين اهيت كده. تمام
اكسلنت. اتفضل يا استاذ.
unusual complications following treatment of clubfoot. Here I was يعني at some stage in my practice I was faced with a situation that I couldn't find an explanation for. This complication was an 11-year-old boy who gave me a history of right clubfoot, typical right clubfoot. He had been treated by the typical Ponseti technique for 1 year, and then it failed for some reason, and then he underwent surgery, and it seems that he had undergone an extensive release. He presented, as the picture shows, with pain on the dorsum of the foot, difficulty in wearing his shoes, repeated falls or decreased agility, as well as the cosmetic deformity that we see in the picture. Another patient, and interestingly enough, always these complications, they come in pairs, as they say. So quite similar age, opposite side, left clubfoot, had been treated only by serial manipulation and casting, never undergone surgery, and he presented with the same complaint. Dorsum of the foot pain, difficulty in his footwear, repeated falls, and cosmetic deformity. At that stage, the diagnosis was not extremely clear to me, but going back to the literature and searching, as we should always do, I came up with the diagnosis of metatarsus elevatus, also known as dorsal bunion. Now, this is a complex deformity that consists of elevation of the first metatarsal head, a plantar flexion contracture of the first metatarsophalangeal joint, and dorsiflexion contracture of the tarsometatarsal joint. Now, why does this happen in some children with club feet, even if they haven't undergone surgery? We have to go back and understand the pathology. And before the pathology of clubfoot, we have to go back and remember the anatomy. Now, the tibialis anterior, we all know it as a dorsiflexor of the ankle. But if we go back to the anatomy books, we will remember where it is inserted at the opposite surface of the peroneus longus, and it elevates the first metatarsal before dorsiflexing the ankle. Its action is counterbalanced by the peroneus longus, which runs all the way on the undersurface of the foot from the lateral side to the medial side. Now, when a muscle imbalance happens between a short and strong tibialis anterior and a long, elongated and weak peroneus longus, the shaft of the first metatarsal becomes dorsiflexed. And this is the beginning of the triggering of the deformity of the dorsal bunion. Why is the tibialis anterior short and strong in club feet? Initially, it is short because of the deformity. Now, when we correct the deformity by the Ponseti or by surgery, the medial arch is restored. This provides the tendon with a straight line of pull, but it increases the tension due to lack of length. Consequently, it is strong and overactive. Why is the peroneus longus elongated and weak? It is outstretched on the convex lateral border. Now, as a secondary compensatory mechanism, the flexor hallucis longus will flex the big toe at the MP joint in order to establish a point of weight bearing. In the early stages, these deformities are not fixed. With time, the joint will subluxate plantar, and the dorsal part of the metatarsal head cartilage will degenerate, causing pain. Now, what can we do to these patients? It is a really troublesome complaint for them. This is the close-up picture of the boy. This is on the operating table with a closer look. Now, what we can do? Again, going back to the history, as I always say in pediatric orthopedics, a lot of the procedures that we are currently describing, maybe in cerebral palsy, maybe in other conditions, they are not newly described operations. Actually, they are operations that had been described in the past, and what we are doing is we are just re-popularizing them, maybe with some modifications. We find that in a lot of the conditions. So in 1940, Lapidus had described a procedure for patients with paralytic feet and poliomyelitis. He did arthrodesis of the first tarsometatarsal joint, capsulorrhaphy of the first metatarsophalangeal joint, and then he transferred the FHL to the distal end of the first metatarsal and transferred the tibialis anterior to the tibialis posterior. Now, modifying on this procedure, some people try to find a solution for the metatarsus elevatus or the dorsal bunion that can complicate sometimes club feet. So in the first International Clubfoot Congress back in 1990, Koo first used the term reverse Jones procedure for an isolated transfer of the FHL to the first metatarsal head in order to change it from a flexor to an extensor. And then in 1991, Tash Dijian described a flexion osteotomy at the base of the first metatarsal, together with transfer of the FHL to the metatarsal head. In 2007, Young reported on the results of the Jones procedure, and Young et al. Concluded that the procedure could provide a lasting and effective correction of the dorsal bunion deformity, but they recommended adding an osteotomy in patients above the age of 10 years. And hence what we describe as the modified Lapidus procedure, which, as we try and explain in this diagram, we will produce a dorsal tongue flap of the metatarsophalangeal joint with its base distal. We shall remove the dorsal exostosis, and then we shall perform a wedge from the base of the first metatarsal shaft distal to the physis with its base plantar, as shown in the diagram, We will close the osteotomy and fix it with wires, and then we shall detach the FHL from its insertion, drill an oblique tunnel in the first metatarsal shaft from dorsal and distal to proximal and plantar, pull out the flexor hallucis longus from this tunnel, and then tie it over itself, and hence converting it into a plantar flexor of the first metatarsophalangeal joint and eliminating its action in producing subluxation of the joint. We shall finally produce a tenotomy of the flexor hallucis brevis and the plantar capsulotomy of the first metatarsophalangeal joint, and then we shall overlap the dorsal capsular flap that we created initially and put the metatarsophalangeal joint in 5 to 10 degrees of dorsiflexion. The results seem to be satisfactory according to the literature. This is before and after, and this is before and after. How can we avoid metatarsus elevatus happening to our patients? A lot of take-home messages. You should not stop your serial casting unless you have established active eversion of the foot. So you know that the balance between the peroneus longus and the tibialis anterior has been restored. You should closely follow up all your children until skeletal maturity for any signs of imbalance between the tibialis anterior and the peroneus longus, with any evidence of dynamic supination or adduction or any loss of active eversion. If any of this is noted, you should subject your child to immediate serial casting. If this persists, you should not hesitate to proceed to tibialis anterior transfer if the child is above the age of 4. A lot of authors recommend in the posteromedial release to do tibialis anterior lengthening to avoid overactive tibialis anterior. So this is the first complication that I'm sure is the most unusual complication that we can see. The second and third complications we might be more familiar with, so I shall go through them more quickly. This was a 6-year-old boy who had bilateral club feet. Again, he had been treated by serial casting, but without tenotomy. He presented with foot deformity, repeated falls, again, difficulty with the footwear, and the pain and callosities on the medial side of the feet. The diagnosis is obvious with the valgus heel. Sometimes its cause is if you do soft tissue release, if you divide the deep part of the deltoid ligament. But in this boy, he had not undergone surgery. So if you do direct and forceful manipulation of the heel, you do prolonged casting, with each cast lasting for more than a week, a number of casts more than 8, you might end up with this complication. I've seen so many babies being treated with what is supposed to be a Ponseti technique. They last in each cast for over a month. Sometimes I hear numbers like 16 and 30 and 40 casts. Some babies spend the whole year of their life being casted. And remember, one of the most characteristic teachings of the Ponseti technique is never, never touch the heel. So you do your manipulation indirectly. Now, what can we do? We can do arthroeresis or the calcaneal stop procedure, or we can do the subtalar extra-articular arthrodesis, or what is known as the Grice green, and putting a peg from the fibula inside the sinus tarsi. It gives quite satisfactory results with improvement of the valgus, as we can see. Now, the last complication is this was a 3-year-old girl who had left clubfoot, had right clubfoot. She had been treated by posteromedial release, including Z-plasty of the Achilles tendon. She presented with the calcaneus deformity and pain and callosities on her heel with difficulty again in the footwear. Again, the diagnosis is obvious. It is an over-lengthened Achilles tendon, and its treatment is shortening with excision of the segment of the tendon and its plication, with good results, but we should try and avoid such cases. Thank you very much.
Thank you so much, Professor Tarek Hassan, for this very interesting talk about unusual complications of Talipes. Thank you so much, sir.
You're welcome.
Now we come to the talk of our beloved professor, Professor Gamal Hosny. Professor of Orthopedic Surgery, Banha University, and the President of the Egyptian Orthopedic Association. Professor Gamal will speak about external fixation in clubfoot. Dr. Gamal?
طارق اقفل الشير بس عشان افتح الشير عندي.
دكتور طارق would you please stop the share please؟
ايوه انا بحاول اهو، ثانيه واحده.
ممكن تقولها انت يا طارق، تقول المحاضره.
يا باشا ما اقدرش. انا بس اعمل الانشير، حد بس يساعدني اروح فين؟
هو حضرتك ستوب شير يا فندم.
حاضر.
شير سكرين تحت وستوب شير يا فندم.
حاضر.
اوكي.
انا بس معلش انا مش عارف.
براحة حضرتك يا فندم.
اتفضل يا بيه.
تمام يا فندم.
معلش تكنولوجي بس فيري بور.
مش عارف هي راحت فين.
حضرتك غالبا ما خدتهاش معاك الغردقه يا دكتور جمال.
غالبا. مش عارف مش قادرة تطلع ليه. دقيقة واحدة.
اتفضل يا فندم. تيك يور تايم فندم.
في الحاجات اللي موجودة كلها. عارف ايه اللخبطه سببها. هفتح واقفل تاني. اخيرا. غالبا طارق كان عايز يقولها.
تمام يا فندم.
انا ما اقدرش يا بيه.
باين اهو. First of all, I would like to thank Professor Mohammed Lashab for inviting me. Thanks, Mohammed.
Thank you, sir.
Great work. And I'm really grateful to have me with Professor Khamis Eldeeb. And thank you, Professor Khamis, for the kind words. Thank you so much. Would like also to thank Professor Hassan Elbarbary, Professor Hisham, Elghany, Professor Tarek, Hassan, and Professor Mazen for sharing me their experiences in this symposium. I'm going to speak about the X-fix or external fixation in clubfoot management. في الأول طبعا بحب أفكركم بالمؤتمر الثاني والسبعين لجمعية جراحة العظام المصرية من 14 ل 17 ديسمبر. المؤتمر إن شاء الله هيتعمل عادي في 3 فنادق: انتركونتيننتال 6 ستارز، توليب، وهوليداي إن. هنعمله في 3 فنادق علشان خاطر قواعد التباعد الاجتماعي، ومنتظرينكم جميعا ان شاء الله. هيبقى فيه حاجات كتيره: ارثروبلاستي، بيدياتريك، اورثوبيدكس، هاند سيرجري، لمب ريكونستراكشن. وفي انتظاركم جميعا ان شاء الله. When we start talking about the external fixation in clubfoot, we have to remember that in most authorities and most facilities, when they talk about clubfoot management by X-fix or Lazarov method, they usually give the people this picture. We talk about العنقاء والخل الوفي، الغول والعنقاء والخل الوفي. ده الغول اللي مش عارف يعني. So they always talk, they always have this at the end of the paper. Elzarov method is technically demanding procedure, lengthy, difficult, and fraught with complications. When I revised these papers, I found one of them talking about 11 patients done over 10 years period. So the experience of the surgeons was almost one case every year. And they gave us their experience with a technically demanding procedure, lengthy, difficult, and fraught with complications. This is quite normal. If it is not your cup of tea, it's not your cup of tea. لما تكون خبرتك في الموضوع حالة كل سنة فغالبا دي مش شغلتك. ولما تكون انت اصلا ما بتشتغلش في النجلكتد كلاب فوت، يعني انت ما عندكش حالات اصلا بس انت مصمم تدينا خبرتك. هو ده لما تدور في الانجليش والامريكان ليترشر على الاكسترنال فيكسيشن هتلاقي كده، لان الحقيقه هو مش ده العيان بتاعه، فهو بيدي خبرته في العيان مش بتاعه، وده ناتشرال انك تلاقي الكونكلوجن ده. وانا ابتديت بيه عشان تعرف من الاول ما يبقاش عندك فكره مسبقه. Conventional surgical treatment of clubfoot is not always successful or easy to apply. انا حضرت الوقت اللي كان الكلاسيك تريتمنت المكاي والسنسناتي ابروتش، وكان اللي يقول كده غير كده كان it was a huge mistake، لان هو ده الكلاسيك تريتمنت ساعتها، وكان في ليميتد مكاي واكستنسيف مكاي. بس عشان الناس المتحمسين جدا للبونسيتي دلوقتي والغيره، وده عادي. You have something in it. There is no one solution for a single problem. Neglected. It's an uncommon condition in the developed world. يعني ايه neglected clubfoot? It means clubfoot coming after 1 week, 1 year, 2 years. The condition is more common in the developing nations as a result of lower detection rates. هي very common or more common in the developing nations. Why you want to give me the method of treatment of neglected clubfoot? لو انت ما عندكش neglected clubfoot، ليه انت مصمم توريني احسن الطرق في علاج neglected clubfoot؟ يعني انت ما عندكش عدد كافي من الحالات، ليه انت عايز تقنعني ان انت عندك الخبره في علاج neglected clubfoot؟ The treatment protocols for clubfoot are usually designed for cases referred at birth, which is quite logical. طب لو جالك العيانه في سن 38 سنه، this is 38 years old woman, and this is the first presentation. So what do you call this? Neglected clubfoot or not? What's the type of treatment you are? So sometimes you are not talking about the same patients. We have arguments, but actually you are not talking about the same patient. And this is another neglected clubfoot. When left untreated beyond walking age, the weight bearing on the side of the foot worsen the deformity, in addition to worsen contractile elements on the side. السنترز اللي ما فيهاش neglected clubfoot، يعني حتى السنترز اللي نادر فيها neglected clubfoot they insist ان هم يدونا ازاي نعالج neglected clubfoot, which is very funny. It's very funny. So treatment traditionally started with casting utilizing the Ponseti technique, followed by extensive open surgery, which may entail soft tissue procedures. Nonsense. Fletcher, this is a review. Many procedures involving osteotomies often results in obviously shortened foot and may be associated with skin necrosis, pseudoarthrosis, infection, vascular damage. These procedures are Also not uncommonly associated with pain, weakness, stiffness of the foot and the ankle postoperatively. And I've seen that myself. When I was young, the natural treatment of neglected clubfoot was triple osteotomy. And you have to remove huge wedges to gain correction. So the foot is almost 1/3 or half the size of the normal foot. And usually it was painful. And very funny. والعين كان تملي يلبس الجزمة يقعد يحط جرايد جوه. So let us talk about external fixation. All the treatment or the external fixation depends upon the law of tension stress. This is Elzarov law. We are going to talk about the biological law. If you want to use circular fixator, is it okay? It's okay. If you want to use unilateral fixator, it's okay. If you want to use TSF, hexapodal, whatever the hardware you are using, we are counting on the law of tension stress. So I always call it Elzarov method. It's not Elzarov external fixator. Even if you use TSF or hexapod or something, it's actually the Elzarov method or gradual treatment. Gradual traction on living tissues stimulates tissue genesis and growth throughout the distraction period. So by appropriately applying loads to various parts of the foot, you are able to change the shape and dimensions towards a specific therapeutic goal. The shape-forming processes acting upon the tissues are dependent upon the magnitude of the applied loads and adequacy of the supply details. We are going to divide the frame into 3 parts: tibial part, hind foot part, holding the calcaneus. Sometimes you need to hold the talus too, especially in cases with minimal invasive technique, because you want to avoid the arthodiastasis. You want to do more lengthening of the foot. And forefoot part. So we have 3 parts: tibial part, hind foot part, and forefoot part. Tibial fixation. Tibial fixation, you can use 1 half ring, 2 half rings. You can use a 3rd level of fixation. You can use wires, 2 wires opposite each other, olive wires. You can use half pins. Why we have this variability? Because we have 2 different cases. You have a huge patient, a fat person. The guy perhaps is 12 years old, but he's very fat. So you need stability. If you want to need stability, perhaps you need 3 rings. You need 3 levels of fixation. You have more than 2 wires. You have 2 olive wires. So this is the diversity. It depends upon the size of the patient. The patient is 35 years old. So you need more fixation. The hind foot fixation. Usually this is the hind foot. You take the shape of the calcaneus. If you have equinus, you have to take it this way. If you have varus, it has to be higher on the medial side. And usually we use half ring or 5/8 rings. يا إما استخدم نص حلقة أو 5/8 حلقة. forefoot fixation. عادة بنستخدم نص حلقة عشان العين يمشي بعد ما تتعدل. Usually we use at least 2 wires. Sometimes use a 3rd wire. Again, people talk about it's more simple to use 1 wire. This is nonsense. It depends upon the patient and the situation. So there is nothing called, I will put this frame, and with this frame, it looks like I'm buying a new car or something like this. This is the wire positions. How many wires you've been using? Again, it depends upon the situation. So you can use for 4 wires or 6 wires or half pins for the tibia. You can use the 3rd level, 1 level, calcaneus, 3 wires. You can use locked wires by olive wires. عادة كنت بستخدم olive wires وبطلت لأن olive wires اللي موجودة the quality is not that good. So And you can use wires for the forefoot. Only in this level, 2 wires, one between the first and the fifth, the second from the first to the second or the third, any combination. Another method بنستخدمه في بعض الحالات again حسب الحالة. One wire at the cuboid, another wire at the base of the fifth metatarsal. If you want to, it depends upon the situation. Can we have a standard configuration? ممكن نحط فريم أنا أعمله. The first time I've learned how to do it in clubfoot, Germany, and we were doing the assembly the day before, and usually it took from us about 5 hours the night before to build the frame. And the next day in the operating theater, we found that this is unsuitable frame, so we dismantle the frame and we do another frame for another 5 hours, so 10 hours. Now we never do this. We don't do a pre-assembly or something. Why? Because there is no standard configuration. Again, this is nonsense. There's nothing called the configuration. Why? Because the first rule is the stability. If you want to have the rule of tension stress, the stability is totally different. If the size of the foot is 9 centimeters or 90 centimeters, if the patient is 2 years old or 38 years old, what difference does it make? The forces are totally different. So there is nothing called standard frame. So this is a frame, and this is another frame, and this is another frame, and this is another frame. Look to that frame. How many levels of fixation? 3, 1, 2, and there is another one above. How many wires? 3 in each frame. Look to the calcaneus. 3 wires in the calcaneus. Some cases, even in the forefoot, we put 2 in the forefoot. It's very rigid. Forefoot adduction. And the patient is old, and this is recurrent. So you need more force, you need more stability. And this is another frame. Look to this frame. We use olive wires. This is arthrogryposis multiplex and congenital. The patient had 8 operations before. Very stiff foot. So we used locked wires by olive wires, and you put another wire here at the cuboid level and 2 wires over there. Look to this frame. What's this? This is not the same frame. We had a subluxation of the talus, so we changed the frame into translational frame. You want to do translation. So we don't have a standard configuration. And sometimes we change the frame many times according to the situation, because the situation changes from 1 week to 1 month, because it's not always the same in all patients. Because you dream about correcting all deformities at the same time, at the same rate. It never happens. I want to tell you, it never happens. Sometimes you have very good correction of the calcaneus, but you still have forefoot adduction. So you have to do more with the forefoot adduction. The techniques. It's not Elizarov method or X-fix is not one technique. We have 3 different techniques: constrained, non-constrained, and semi-constrained. What's the difference between constrained, non-constrained, and semi-constrained? All the 3, they work it out. All the 3 of them. So we don't have one system. This is the non-constrained system. In the non-constrained system, we don't use hinges. We use only motors or distractors. So if you have varus heel with forefoot adduction, use a motor in the near the the varus side, just motor. Where is the hinge? We usually consider the apex of the deformity, the pathologic apex of the deformity is the hinge. So we don't use hinges. So if you want to do it this way, you can have only one motor or two motors. You can have a distractor medially in the, like this one, you saw. You don't have any hinge on the lateral side because you have a distractor on the medial side. So this is non-constrained frame. The non-constrained frame, because sometimes you have some subluxation, perhaps in the talonavicular and you connect it, or in the talus, and I will show you an example. Constrain the frame. In the constrained frame, you do the motor or the distractor here, and you have hinges. Usually the hinges at the level of correction. So if you have distractor posteriorly, you have the hinges opposite the hind foot, usually at the ankle joint. This is the constrained frame. Semi-constrained, it's in between. The three of them are working, no problem at all. There is nothing in the literature to conclude that there is one way is better than the other method. You can use different methods. You can use unilateral fixator like his, fixator from India, TSF, or hexapod. No problem. This is the hardware. It doesn't make any difference. Whatever the method you've been using, it's the law of tension to gain forefoot adduction. One of them is to use the olive wire laterally and another olive wire, and you put it on a screw traction device. With the screw traction device, you push this part 1 millimeter per day. So you can correct the forefoot adduction. Another method, differential lengthening between the medial and lateral. Another method, so you can do just distraction here without using a hinge there. Or you can use distraction here and putting a hinge opposite the apex of the deformity. They are all working out. Correction of cavus. Again, one method is to do a distraction between the calcaneal ring and the forefoot ring. And you can use hinges also here at the apex. We all know that the cavus can be at the level of the first metatarsal, the midfoot, the posterior part. So you put your hinge over this part, or you don't use a hinge, no problem at all. The supination deformity, you can use one link on the lateral side. So if you are going to have a rotational, it's the supination. Or you can use two links here and differential lengthening to do supination or pronation according to the situation. Again, we can use two techniques, the bloodless technique without any surgical incision or the minimal invasive technique with osteotomy. And this is an example of the bloodless technique with arthrogryposis. And this is totally constrained or constrained the frame with hinges, distractor posteriorly. And you can have full correction with gradual correction. Because sometimes you have clawing of the toes, you can use just استك بس علشان ترفع التوز عشان ما يحصلش contractures of the toes. Overcorrection of the rule. If you are going to use the bloodless technique, you have to do overcorrection. It's very hard to have overcorrection on the long-term follow-up. But if you want to do the bloodless technique, usually you have if you don't do overcorrection, you have relapse of part of the deformity. So I advise you from now, after all those years, that you have to do an overcorrection. And don't be afraid that the overcorrection we're going to give you the opposite deformity. No, it's not. I didn't see that except in one case, perhaps there was soft tissue imbalance or something like this. Because, but you have to take care of the soft tissue imbalance, especially with cavus foot. Cavus foot soft tissue imbalance is very important to correct with the bony procedure. For the minimally invasive, we can use V or Y-shaped osteotomy. If you want to do lengthening of the foot, sometimes you need to do lengthening. It's very short foot. a patient will not be satisfied. If you have a plant, just a plantigrade foot, the patient will not be satisfied. So you need lengthening. If you want to do lengthening, you better have V-shaped osteotomy. If you want to correct it, Y-shaped osteotomy is okay. And this is the V-shaped osteotomy. And with lengthening, again, V-shaped osteotomy. I took it from paper with Hisham Shalabi and Hani Hifni, 2000, very good paper about V-shaped osteotomy. And this is the U-shaped osteotomy. And this is an example, you know, the patient had arthrodesis before, with deformity. You can do V-shaped osteotomy. See the osteotomy, the second limb. This is the first limb, and this is the second limb. Unfortunately, the frame won't allow you to see the exact shape of the osteotomy. So it's not the magic lamp. Elizarov is not a magic lamp or something. No, you have complications. We do have complications. Pin-track infection, no problem at all. Unfortunately, some people, they usually compare the pin-track infection with the wires, with the infection of the plates and the screws. Again, it's very strange. Talar subluxation or dislocation. I've heard a lot about talar subluxation or dislocation. Yes, I have cases with talar subluxation. Look to the talar subluxation. What are you going to do? What I've seen in the literature, if they have talar subluxation, they take the patient to the operating theater again and they correct it and they put wires. We never do this. We change the frame. This is the translational mode. You see, this is the translation. So the foot, the talus is translated anteriorly. So I'm going to push it back posteriorly 1 millimeter per day. So look now, we have complete correction by the translation mode. You see before and after, gradual translation, posterior translation. So you don't have to take the patient to the operating theater again. You just do translation, you change the frame. How to prevent talar subluxation? Talar subluxation comes usually in the bloodless technique from the direction of distraction. This is the direction of the distraction. If you want to prevent it, you have to do posterior distraction, not this one. You see here, it's not posterior, it's just vertical to the foot or anterior. So for me now, all the distractor has to be directed posteriorly. I can hardly have a case now with subluxation of the talus after this posterior distraction. Again, this is the bloodless technique. In this patient, she had 5 previous operations. She was 12 years old. One of the old cases, I usually used at the time unilateral hinges. Now use only universal hinges, and this is afterwards. And after 11 years, the range of motion, she still have range of motion, but it was stiff before and stiff now. And this is after 11 years. And this is the function, because the people always talk about the function. She's not functioning well, and Elizarov, she's going to have painful foot. Sorry. And in conclusion, the distraction osteogenesis principle is a useful option and can be considered as a rescue solution in complex deformities. However, its execution by surgeons with considerable expertise in application. هو الابليكيشن في رأيي مش مهم، هو الاكسبرتيز الحقيقية في الفولو اب. يعني when the people come to learn how to do it, I teach them that they have to go to my outpatient clinic. في العمليات احنا ما بنعملش اي حاجه ليها اي قيمه الحقيقه، احنا بنحط وايرز وهاف بينز، وساعات الحكيمات تعرف تحط وايرز وهاف بينز. الريال اكسبيرينس مش في الاوبريتنج ثيتر، ما فيش اي حاجه. ما ساعات نشوف حد يقول لي شوف انا حطيت الازاف ده حلو قوي، شايف وانا حطيته مش عارف في كذا، هو مستغرب جدا. يعني ايه حطيت الظرف؟ معرفش. لان هو ريال اكسبيرينس في الفول اب مش في العمليه. ودي خبره الناس الثانيه اللي هم بيشتغلوا في الموضوع. دي اول بيبر عملتها كانت سنه 2002. ايدج ليميتس. برضه ناس مصممين يحطوا ايدج ليميتس. واحد حاطط 6 years وقال لك عشان الفوت بتبقى صغيره ومش كذا. والتاني قال لك لا الايدج ليميت مش عارف كذا. طبعا unfortunately معظم الاماكن اللي بتتكلم عن الموضوع ده ما بتشتغلش في الموضوع. طبعا كل واحد بيتكلم حسب خبرته زي الارثروبلاستي. مش فاهم ليه يعني في الارثروبلاستي تملي يتكلموا على السيرجيكال لود. فيقول لك لا هو السنتر ده او الجراح ده بيعمل 4 أيام في الاسبوع فخبرته في الارثروبلاستي 24 حاله فنقدر نقول عليه كذا. لو عمل اقل من 50 حاله في السنه يبقى كاجوال سيرجن من 50 ل 100 يعني. لكن في اشمعنى في دي people are trying to ignore the load and they claim experience and they claim that they give us their conclusions, especially in the West. They give us a very sharp conclusion based upon the experience of one patient per year. بالمناسبة طبعا السنتر اللي مطلع ده اللي بيعمل 1 patient per year فيه 5 جراحين. يعني خبرة كل جراح حوالي 5 عيان كل سنة. يعني كل جراح بيعمل تقريبا 5 عملية كل سنة. لكن مصممين يدونا الاكسبيرينس بتاعتهم. معلش. In my patients, the lower age limit was 2 years. But I've done lower than this because the patient have 2 or 3 previous operations at the age 2 years. Many surgeons now in the neglected clubfoot are moving away from the Ponseti technique as well as soft tissue release in favor of distraction techniques. بس في واقع الامر في الديستراكشن تكنيكس ابتدى بعضهم يعمل الظرف وبعدين يعمل سوفت تيشو. يعني هو بيعملوا از بريمير ستيب لمجرد الديستراكشن بتاع السوفت تيشوز. reported complications مني او من غيري did not affect the outcome. The stiff deformed foot preoperatively has been corrected to a stiff plantigrade corrected postoperatively. بعض الناس, some people talk about the range of motion. Yes, it's okay. We have a stiff, painful, not deformed foot. Now we have a stiff plantigrade foot. What a great achievement. انت متوقع يبقى هو stiff before the operation. And you do even whatever you do post release or whatever you do هتبقى a movable foot بعدها. The indication, perhaps the indications for the people neglected clubfoot, relapsed clubfoot, shortened neurovascular structures, unhealthy skin infection, previous fusions or non-unions. مع العلم, we didn't talk about the soft tissue balance. It's another topic. Soft tissue balance is a very important topic, especially in case of cavus deformity. But this has to be a special talk. If we talk about cavus alone, I would rather talk about the soft tissue balance before talking about the bony correction. My conclusion, there is more than one possible solution for each problem. Don't talk about the golden solution or the real solution. I've seen that a lot. In my age, I've seen people talking about McKay procedure and Cincinnati procedure and the best solution on earth and the best results on earth. But now, who's talking about McKay or Cincinnati operation? So my conclusion, there is more than one possible solution for each problem. Thank you. Shukran.
Thank you so much, Professor Gamal Hosny, for sharing with us your very long experience about external fixation in clubfoot. Thank you, sir. بنفكر حضراتكم at the end of all talks we have a surprise. We have the original DVD of Ignacio Ponseti. We will show it to you. ال DVD ده هيبقى فيه ال original technique of Ponseti and he will present it by himself. Now we come to the next talk, which is a very interesting talk done by Professor Mazen Samir from Mansoura University. Professor Mazen will speak about relapsed clubfoot. Professor Mazen.
Thank you very much, Professor Mohammed.
Yes, sir. Full screen, sir, please.
Sorry?
Full screen. Yes, yes, yes. Yeah.
Okay.
Thank you, sir.
Thank you very much, Professor Mohammed Al-Ashhab, for inviting me for this fruitful Zoom meeting. Also, I'd like, I am very happy to be with Professor Khamis Eldeeb, Professor Gamal Hosny, Professor Hisham Elghany, Professor Talipes Hassan, and Professor Hassan Elbarbary, and Professor Ahmed Alam. Thank you very much for being with you and sharing our knowledge about congenital Talipes Equino-varus. My talk today is about relapsed clubfoot. In this presentation, we will discuss the background of relapsed clubfoot, how to differentiate between relapsed, recurrent, and neglected clubfoot, discussion about the risk factors for relapsed clubfoot, classification and identification of relapse pattern, evaluation and the treatment of relapsed clubfoot, and finally, take-home message. Although Ponseti method is now the gold standard technique for treating clubfoot, even this method has not solved the problem of relapse completely. Ponseti stated that the clubfoot has an inherent and stubborn tendency to relapse. Relapse following the Ponseti method is very common and has been reported up to 48% by various authors. A relapsed deformity is seen most frequently and quickly during a period of rapid growth of the foot, that's to say during the first 5 years of life. It is seen rarely in patients after the age of 5 and extremely rare after the age of 7 years. So, we should differentiate between relapse, residual, and the neglected clubfoot. A relapse can be defined as recurrence of deformity in a previously well-corrected foot. This is to differentiate it from residual clubfoot, in which the foot is partially corrected rather than fully corrected. Finally, for the foot in older patients that was never treated at all, we refer to this situation as neglected club feet. Despite numerous studies investigating various risk factors, it has been difficult to predict which feet are at risk of relapse. Risk factors include, first of all, non-compliance with the brace, muscle imbalance, low socioeconomic and education levels, non-idiopathic club feet, severity of initial deformity, age at the time of treatment, and number of casts required. Non-compliance with the brace is the leading cause of recurrence, with reported incidence up to 45%. Ponseti postulated that failure to use the brace to maintain the corrected clubfoot in external rotation will allow it the ball of retracting fibrosis. Professor Khamis Eldeeb today tell us about the pathoanatomy and said that Ponseti, one of his theory is retracting fibrosis. So retracting fibrosis in the ligament and tendons around the medial aspect of the foot and ankle, causing the deformity to return. And also Professor Hisham insisted that, as we see in this picture, the affected foot is externally rotated in about 70 degrees, while the non-affected foot is externally rotated in 40 degrees. There are certain strategies to encourage consistent brace use and preventing relapse. And we should know that relapse should be considered as teachable moments to emphasize the importance of brace. We should stress to the parents the importance of the post-corrective bracing during a prenatal consultation, the first clinic visit, and all subsequent visits. Also, we recommend them that the brace should be used at night and at sleeping time. And when the brace is initiated, we should learn the parents or we should allow the parents to apply and remove the brace while we are around them in the room. Another strategies, if there is any concern about the parents' ability to apply the brace, we should ask the family to return the following week to make certain no problem with the brace or skill have occurred. Also, we should address any skin problems, refrain from criticizing the family, and remind parents that walking does not substitute for bracing, and we should tell them to continue on bracing at sleeping time. So, how can we explain the possibility of recurrence after successful brace wear and good compliance? This important point drives some investigators to suggest that a muscle imbalance may play a role in the development of relapsed deformity. Gelfer et al. Reported a poor evertor muscle activity as a potential risk for recurrence. And also, Moon et al. Give us another evidence indicating the role of muscle imbalance in his MRI study when he showed us extensive soft tissue abnormalities, including intramuscular fat replacement and unique patterns of hypoplasia in some specific muscles group. And this is the poor evertor muscle activity make us tell the patient, Professor Hisham told us today that we should leave the brace for at least 5 years. And this is standard for the application of the brace. And the other thing we should add that we should make sure that this patient can evert his foot actively while we remove the brace at 4 years. Bashkar and Batani identified 5 relapse patterns based on identification involvement of dorsiflexion, adduction, supination, and whether the deformity was either dynamic or fixed. Loss of dorsiflexion is the earliest sign of relapse. So if we have loss of ankle dorsiflexion from 15 to neutral, while the knee is in extension, this is the early signs of relapse. Another pattern of relapse is dynamic for foot adduction and also supination of the foot. Grade 1A and grade 1B both are flexible relapse pattern. Fixed equinus of any degree and passive and we can't have passive correction to neutral is considered grade 2A, and fixed adduction of the forefoot and midfoot with fixed lateral curvature is also considered grade 2B. 2 or more fixed deformity is considered grade 3. So this is the classification for a relapse pattern following Ponseti treatment. Now we come to the evaluation of relapsed clubfoot. So first of all, we should ask ourselves, is this deformity represent uncorrected or relapsed deformity? It is believed that the majority of recurrence after the Ponseti methods are due to insufficient correction rather than the actual recurrence. However, the possibility of rate recurrence after complete correction of clubfoot deformity has been reported. And this is make our attention whether we are dealing with idiopathic clubfoot or non-idiopathic type. The other question is the correction was initially obtained, and if, why was it not maintained? Is it due to non-compliance with the brace? Is it due to low socioeconomic and educational level, or it is due to non-idiopathic types of Talipes Equino-varus? Third question, where is the site of uncorrected pathology? Is it in the hind foot or in the midfoot or both? Is there an imbalance between the function of tibialis anterior and the peroneal tendon, as Professor Tarek tell us today, What about the columns of the foot? Are they in balance or not? Is the medial column short due to dysplastic talus or dorsolateral dislocation of the navicular, or is the lateral column of the foot is too long? And we should always must consider the age of the patient and as a result of the initial treatment. Now we come to the treatment option of relapsed clubfoot. As Ponseti said, and Dr. and Professor Hisham insisted today, treatment option of relapsed clubfoot is remanipulation, remanipulation, remanipulation. And I agree totally with Professor Hisham about that. But as Professor Khamis said, we have those patients which will have surgical management. Indeed, it is now not like 10 years ago, the number is decreased, but we should not lose our surgical skills because we have now some cases which need surgical operation. So the treatment option of relapsed clubfoot is remanipulation, casting with or without Achilles tenotomy, tibialis anterior tendon transfer, soft tissue release operation, some bone procedures, combination of the above procedure, or as Professor Gamal Hosny told us, external fixator, and also Dr. Hassan Elbarbary will tell us about his experience about that. So if we have loss of ankle dorsiflexion, what should we do? If the ankle is unable to dorsiflex passively 10 degrees, or the foot cannot fit easily into the brace, then manipulation and the cast application will be done for 2 or 3 sessions with 1 week apart, followed by foot abduction orthosis. Repeated Achilles tenotomy can be done if ankle dorsiflexion is less than 15 degrees and should take place in the operating theater as many open procedure under general anesthesia, as the tendon may be scarred and you are afraid of injury the nearby posterior tibial neurovascular bundle. Tibialis anterior lengthening with or without posterior ankle and subtalar osteotomy capsulotomy is sometimes needed to correct the fixed ankle equinus, but it is associated with ankle stiffness. If we have a patient presented with dynamic forefoot adduction and midfoot supination, tibialis anterior tendon transfer is the solution, but there are certain precautions. The age of the patient should be more than 3 years, so that we have sufficient ossification in the third cuneiform to allow bone to tendon healing. The tendon should be transferred to the third cuneiform rather than the cuboid to reduce the risk of overcorrection. Also, we should not transfer the whole tendon as proposed by some surgeon. Ponseti insists that transfer tendon should never be split to avoid weakening of its eversion power. The foot should be supple and passively correctable before do tibialis anterior transfer. But if we have stiff feet that are not fully passive corrected, we should do preoperative Ponseti serial casting. It is common to have concomitant Achilles lengthening with tibialis anterior transfer, and this occurs if the ankle dorsiflexion is less than 10 degrees. If we need to do a concomitant posterior capsulotomy, we should delay the tibialis anterior transfer for a time, because posterior capsulotomy tibialis anterior transfer needs 6 weeks until healing, until bone to tendon healing occur. But posterior capsulotomy, if we put the cast for 6 weeks after posterior capsulotomy of the ankle and subtalar, we will end with sure stiffness of these joints. So if we have to do posterior capsulotomy, so we will do this operation first with tendo Achilles lengthening, and later on we can do tibialis anterior transfer. Foot abduction bracing after tibialis anterior transfer is no longer needed because the effervescing force of the transfer tendon remains a correction, and some authors consider tibialis anterior transfer as a biological brace. So, relapsed fixed adduction deformity with midfoot supination is known as the bean-shaped foot. And in this deformity, we will have imbalance between the elongated lateral column and the shortened medial column. So the most logic approach to address this pathology in children aged 5 to 9 years is the combined procedure of shortening the lateral column, and the lengthening of the medial column. Children aged 5 to 9 years have well-developed ossific medial cuneiform ossific nuclei, result in low risk of graft extrusion. A closing wedge osteotomy is performed through the cuboid, and we have this graft from the cuboid and put it on the medial cuneiform. In Mansoura University, myself and Professor Elghany done combined double tarsal wedge osteotomy with transcuneiform osteotomy for severe cases in which we have a scene which cannot be just resoluted by double tarsal osteotomy. There are some radiographs which we relied on as indicator of forefoot adductions and forefoot supination. The technique involves a separate incision over the medial cuneiform and the cuboid. The lateral incision allowed reflection of the extensor digitorum brevis and exposure of the cuboid. The peroneal tendons are identified and retracted laterally. The appropriate dorsolateral based wedge of the cuboid bone was removed. Tibialis anterior tendon was identified. With aid of image intensifier, osteotome was used to make a slightly curved osteotomy starting from the medial cuneiform. Transcuneiform osteotomy with osteotome exit at the apex of osteotomy, and the wedge of bone taken from the cuboid bone was inserted into the medial cuneiform. The graft was secured with 1 or 2 wires, and the lateral cuboid wedge was closed and held also with 1 or 2 wires. This is the preoperative and last follow-up of bilateral case. Another case with bean-shaped foot, 39 years old, last follow-up, and the X-ray. What about hindfoot varus? First of all, we should use a Coleman block test to differentiate whether the hindfoot varus is flexible or rigid. Hindfoot varus deformity can be treated by complete subtalar release and or lateral closing wedge calcaneal osteotomy. The disadvantage of closing lateral wedge osteotomy is the decrease of the height of the heel and may lead to lateral impingement problem. So we always do, we better to do lateral displacement osteotomy. What about the fixed Equino-varus deformity? Equinus of the forefoot is also called the cavus and can be defined as plantar flexed first metatarsal, as Professor Hisham told us early in this meeting. And the treatment in mild case is plantar fasciotomy. Mubarak et al. Described an operation salvage procedure for severe Equino-varus foot deformity in which they do navicular excision and cuboid closing wedge osteotomy so that they can lose the stiff foot and put them in a proper position. Since the wide adoption of the Ponseti method, the use of extensive tissue procedures to treat idiopathic clubfoot deformity has declined, and with reported incidence only up to 16%. And that is why, again, I insist we should know that treatment even of relapsed clubfoot should be remanipulation, and some small cases needs interference. And as Professor Khamis Eldeeb told us today, we can do extensive posterior medial and lateral release, or we can do a la carte posterior medial and lateral release surgery. And a la carte approach to release surgery may be the best approach to preserve the strength and the motion of the foot. Professor Gamal Hosny tell us today about the external fixator and the Elzarov principles in treating relapsed clubfoot, and also Professor Elbarbary will tell us about his experience. Salvage operations, such as triple arthrodesis in elderly children at the age of 9 to 12, or telectomy can be done in some elective cases, especially neuropathic or arthrogrypotic type. Take-home message: relapsed clubfoot, relapsed deformity is a common problem associated with the Ponseti method of clubfoot treatment. It usually results from non-compliance with the foot abduction brace. Relapse pattern range from mild loss of ankle dorsiflexion up to release of all components of deformity, rigid Talipes Equino-varus foot. Surgical treatment is indicated for the occasional patient whose foot does not respond to manipulation and the cast application alone. Thank you for your attention.
Thank you so much, Professor Mazen Samir, for discussing this very interesting talk in this interesting subject, the relapsed clubfoot. You have discussed, sir, all the topics regarding the relapsed clubfoot. Thank you so much, sir.
Thank you.
Now we come to the final talk in this very fruitful scientific night, which is a very interesting talk by an eminent professor, Professor Hassan Elbarbary, Cairo University. He will speak about the Elreish frame for management of relapsed clubfoot. Thank you, sir, for joining us tonight. Thank you, Professor Hassan. Professor Hassan?
Unmute, ya Hassan. Unmute.
Thank you, Professor Dr. Thank you, Professor Dr. Mohammed Al-Ashhab, and thank you, Professor Dr. Khamis Eldeeb, for being with you today. Thanks a lot to Professor Dr. Gamal Hosny. It's a great honor to be with you all, Professor Dr. Hisham Elghany, Professor Dr. Tarek Hassan, and Professor Dr. Mazen Samir. Lastly, I'm going to present our experience, the Elreish frame, or the external fixator Elzarov, in the management of relapsed and neglected club feet. Today we're going to talk about the indications for the application of such a frame. زي ما all of the professors stated, ان زمان كان التراديشن ان احنا بنعمل traditional surgeries، فكان عندنا relapsed cases كتيره قوي surgically treated، فكان بيبقى البest solution for such cases هي الإلزارov frame. Nowadays, after the introduction of the Ponseti technique, still the management of the relapsed cases after the Ponseti is to redo another manipulation and again redo the Ponseti technique. The use of the Elzarov frame is only used for such cases that had been treated surgically before, or these who present very late, as the cases shown by Professor Dr. Gamal Hosny, or for the highly complicated cases, as I'll show to you in this presentation. What I have to state that النهارده يعني we're thinking about which frame. Dr. Gamal stated that there is no classic frame for all cases. I agree totally with this. but our frame is a very simple frame that can be used in most of the cases with very mild changes according to the case. I'll show to you that it's more or less, it's very simple to use, and that changing very small parts during the application can make it universally used for most of the cases. As I stated, that we use this frame in the relapsed cases, of course, after surgical treatment, not after Ponseti. Also in the neglected clubfoot presenting in very older age of life, above the age of 6 or 8, and in the complex foot deformities. Few literature described different Elzarov frames, but when we reviewed such cases about 20 years ago, we found that most of them are using two complicated frames with anterior connecting rods, which we don't like in our center in Elreish. Also, they used multiple hinges and multiple distractors for each deformity, and this made the correction takes very long time, and at the same time, such hinges block the action of the other motors. We thought about having an ideal frame, which is very difficult to reach. We need to have a very simple frame with very few components. It should have very lightweight and easy to apply, that can be applied with senior residents. It doesn't need a very specialized surgeon. It should be very easy to use by the parents and should be well tolerated by the child. We hope that it can lead to rapid correction of the deformity. It could be versatile and highly forgiving, as I stated, that it can be applied in different deformities with the same principles, just modifying some parts of the frame or some part in the type of the correction. This is the deformity that has been explained by my colleagues, the equinus, the varus, the cavus, and the metatarsal adductus. In 2004, we presented our paper in the Journal of International Orthopedics. It stated that we used a very simple frame in correction of relapsed and neglected club feet. And since then, we've been using the same frame, and for the next 16 years, very minimal changes had been added to this frame. I'm gonna present this frame. It is a totally unconstrained frame, composed, of course, of one tibial ring. Originally we used two, but later on we found it only one ring is more than enough. We used a hind foot half ring and a forefoot half ring, or 5/8 of the ring. The biomechanics of the frame is that, as I stated, it's formed of here one ring or two rings, and here a half ring, and here a 5/8 of the ring or half ring. We deal with the deformity as two deformities: a hind foot deformity composed of the hind foot equinus and varus, and the forefoot deformity, which is composed of the cavus, the metatarsus adductus. Using posteriorly a hinge located anterior and lateral to the ankle and subtalar joint, and one motor posterior or medially, we can correct both and simultaneously the ankle and subtalar joint. And putting the hinge anterior and lateral to the ankle and subtalar joint allows distraction in the same time of correction of the heel varus and hindfoot equinus. Correcting the forefoot deformity, we used these two hinges. It's a male post located on the medial side as well as on the lateral side. And through differential distraction between the medial and lateral, just we do here, for instance, 2 millimeters per day, and here 1 millimeter. This difference allows correction of all the three deformities, the cavus and the metatarsus adductus, and it allows swiveling of the forefoot around the fixed hindfoot. The hinge here is an imaginary point just between these two hinges. It's located a bit posterior to the mid-tarsal joint, and thus when this half ring rotates around the hindfoot, we have the forefoot getting lateral and correcting the talo first metatarsal axis, as you will see in the next slides. Again, here, as I stated, we're correcting the hindfoot equino-varus deformity through this distraction, and the forefoot adduction and cavus through this differential distraction between the medial and the lateral rods. And as I stated, these are the hinges concerning for the forefoot correction, and this universal hinge is concerned with correction of the hindfoot equinus and the varus of the heel. This is the frame and how it looks. This is the distraction of this rod against this hinge located anterolaterally corrects both the hindfoot equinus and the heel varus. If we need to correct more the hindfoot equinus, just we take this motor a bit more posterior, so it acts more in the plane, correcting the hindfoot equinus. If we have more hindfoot varus, just we take it more medially, it corrects the varus more than the equinus. Also, this is how we correct the forefoot through the differential distraction between the medial and lateral rods, and at the same time swiveling of the forefoot around the fixed hindfoot, causing translation of the forefoot around the fixed hindfoot with the talus, gets correction of the talo-first metatarsal axis. The advantage of this frame is that it decreases the number of rods. As I stated here, we have only 3 moving rods. It's very simple to be informed to the parents. And according to the deformity, we can change the protocol as the rate of distraction posteriorly, medially, and laterally. Also, it allows simultaneous correction of all of the deformities, as we has got no connection between the tibial ring and the metatarsal ring. We think this is one of the greatest advantages in this frame. It's very versatile, it's totally unconstrained, and it allows correction of all the deformities in the same time. Also, allowing distraction in all the planes, we make the foot more supple. We're opening a space for the talus, and the foot is rotating around this talus in this space. As I stated here, we do distraction at the ankle. Differential distraction, both medially and laterally, allows distraction of the forefoot, leaving the hindfoot free and creating a space also for the talus to rotate around. The fourth part is that, as I stated, we have the connecting rods between the talus, between the tibial and metatarsal half ring. We don't have this connection, and this allows more freedom in the correction. We think that this frame is very simple. It has very few components. It's very light in weight and very easy to apply. It's very easy to use by the parents, only 3 rods to distract. It's very well tolerated by the child, as it's very light in weight. Also, we can achieve the correction very rapidly because we correct all of the deformities simultaneously. It's very versatile and highly forgiving. If we have any problem during the follow-up of the case, as Professor Dr. Gamal stated, the art of Elizarov correction is not to apply the frame correctly, but is mostly to follow up and realize any problem and deal with it safely. How do we apply this frame? As I stated, it's very simple. It takes about 20 minutes. It's totally pre-assembled. We make the frame with the same angles equivalent to the deformity that we have. We start, me, Hisham, and Hijaz application of this frame 21 years ago. And I think still till now, we use the same frame. The frame, as I stated, we start with application of the tibial wire. Then we apply the calcaneal wire. Sorry, first we apply the calcaneal wire. Next, we apply the tibial wire. And lastly, we apply a metatarsal wire. Then we augment the tibial ring with 2 pins, and we augment the calcaneal half ring. We use the wire, and then we applied another pin. Concerning the metatarsals, we applied a blocking wire to prevent movement of the foot along one wire, and we should add another wire to make it more fixed so as not to be translated and hit the medial side of the foot by the half ring. The rate of distraction is variable according to the type of the deformity, but mostly we start with 3 millimeters posteriorly and 1 millimeter laterally and 2 millimeters medially. It's 3 to 1 posteriorly, then medially, then laterally. And according to the rate of correction and the follow-up, we can change this. Mostly after 2 weeks, we stop the lateral distraction and we decrease the medial distraction from 2 millimeters per day to 1 millimeter per day. Usually we do pinning of the toes to prevent subluxation and dislocation in severe cases. We do overcorrection in all cases, and we keep the frame for 2 weeks after correction, allowing for the soft tissues to reach its normal or its good length and allow some remodeling of the bones. We should then do a removal and above knee cast for 2 weeks to be followed by 6 months of night splint. We prefer the external rotation monolateral night splint, or some surgeons prefer the Dennis Brown splint. I'm going to present some cases. This is an 8-year-old boy with relapsed talipes. He had several previous operations, which was the state 20 years ago. This is the frame which was used 20 years ago. It's composed of 2 rings. Later on, we used only 1 ring. And this is how it looked after correction and his x-rays. Another very difficult case, this is a girl, she's 17 years old. She came with this severe deformity. She had a wound on the head of the talus. It's completely neglected. And this is her x-ray. This is after application of the frame. Here we didn't use the pins through the toes, but I think later on I prefer to use these pins that prevents the subluxation or the dislocation. This is her x-rays at the follow-up. She had only the flat top talus, but the navicular is well aligned with the first metatarsal in both views. As I stated, this frame allows swiveling of the forefoot around the hind foot and correcting the talo first metatarsal axis. This is how she looked after the correction. And this is her final follow-up. It was about 1 year after the operation. Another boy, he had a vascular injury or a vascular insult. He's from Mansoura. He came to one of my dearest colleagues, Professor Dr. Ahmed Kholeif. He had such a very ugly deformity. He had, here was the site of gangrenous patch. He lost his toes in the original insult, and he did 1 tenotomy before our operation. This is how his leg looks before the operation. This is how he walks. This is just after correction. We reached all of this correction within 6 weeks. He came to remove the frame.
خلص دلوقتي اخر واحد واقف معاهم بقى سنه طول لا مش هقول فده راح.
And this is the site of the gangrenous patch that he originally had with the first injury. This is how he looks after the removal of the frame. This is how he used to walk before, and this is how he is now walking. I think he had a very marvelous result. His parents are really very happy with the end. Lastly, I'm going to show a case of a neglected deformity. This is a young lady. She's 22 years old when she presented to my dear Professor Walid Abeid. She had no surgeries before except trials of casting. She's living in El-Dakhla, about more than 1,000 kilometers away from Cairo. She came to seeking medical advice because she's not married. She's walking on this callosity. This is how her foot looks like. This is her X-ray. She had no operations before and it's completely neglected. We applied for her the same frame, but with some modifications. We did for her, of course, a percutaneous tenotomy to open space to put the frame in an easier way. And this is again her callosity. We do pinning of the 5 toes to prevent subluxation of the toes during the correction of the case. This is how she looked just 2 months after full correction. Again, here is the callosity where she used to walk. This is how she looked after removal, and this is the site where she used to walk originally. This is the site of the callosity where she used to walk. This is how she looked after removal. 20 years later, she visited me again. This is her last X-rays. She had only a flat top talus, some arthritic changes, of course, on the talus, but she's functioning very well. She didn't do any further operation. And this is her nice child. The only thing that she still has is her callosity where she used to walk for more than 20 years. Thank you very much.
Thank you so much, Professor Hassan Elbarbary, for this interesting talk about this very simple frame. Thank you so much, sir.
Thank you, Professor Muhammad.
Thank you. Now we come to the surprise of this night, which is we will show you a DVD, the original DVD by Ignacio Ponseti that illustrates the technique of Ponseti technique for manipulation and casting. Dr. Ahmed Sheikh, may you present the DVD, please?
واضح كده يا فندم؟
واضح يا دكتور أحمد.
Ponseti treatment is based on the concept of the calcaneopedis block, originally described by Inman in 1976. According to this concept, the midfoot and the calcaneus form a functional unit, and most of the motion in the joints takes place around the talus. This is why the correction of the deformity must be made against a fixed talus and not at the calcaneocuboid joint as described in other redressment methods. The talus is kept in place using the thumb of the right hand without fixing the calcaneus at the same time. The motion of the calcaneopedis block around the talus can be seen clearly in abduction. Motion of the single joints in the midfoot is minimal and not relevant to correcting clubfoot deformity. Another important element in the Ponseti method is the direction of manipulation. The foot is first manipulated in supination and then in abduction. The foot is corrected against the fixed talus here. The supination at the beginning of treatment is necessary to correct the slightly pronated position of the forefoot with respect to the hindfoot. When applying the first plasticast, manipulation in this direction corrects the cavus foot component. The second crucial concept in the Ponseti treatment is the kinematic coupling. A varied alignment of the 3 articular facets of the subtalar joint creates a complex movement pattern, which ultimately boils down to a combination of a varus position of the heel, plantar flexion, a deduction, and inversion of the calcaneus. All components can be seen to a minimal degree in this healthy child. By correcting the deformities along one joint plane, the correction of the other planes of movement occurs simultaneously, and without direct manipulation, due to the mandatory movement direction in the subtalar joint. This too can easily be seen in the child with normal feet. The dorsal extension simultaneously achieves vagization, eversion, and abduction. In the lateral projection, we see the calcaneus emerge from its position beneath the head of the talus and move into the synostarsi. Thus, if only the forefoot is abducted, this results in an improvement of the equinus. Please pay attention to the parallel position of the talus and the calcaneus and the improvement of the position with respect to each other. Observing the talocalcaneal angle described by Kite in the lateral plane, we can also see this in the radiographic assessment before and after the correction. The heel varus will also not be corrected by direct manipulation. Due to the kinematic coupling we mentioned before, the hind foot will be brought into the valgus position by abduction. This is done without applying any pressure to the heel. The calcaneofibular ligament is being stretched. Once more, a demonstration of incorrect manipulation techniques on the calcaneocuboid joint. Correction of the adductus is achieved through a secondary deformation in the midfoot area. It is not possible to correct the deformity along the other planes by fixing the calcaneus. Instead, a manipulation against the fixed talus corrects the clubfoot in a natural way by complying with the physiological movement direction in the subtalar joint. The example here shows a 5-day-old baby with bilateral idiopathic clubfoot. At the beginning of every casting session, the foot is examined before manipulation. Common classification systems, like the ones described by Di Meglio or Pirani, are used. The Pirani score assesses 6 criteria of the clubfoot. Each criterion is given a full point if development has reached its maximum stage. In the right foot, we can see only a slight medial crease, but a marked deep posterior crease. The adductus is being examined. The distance between the navicular and the medial malleolus may also be used for further assessment. The heel pad is soft with a high calcaneal inclination. The equinus component is about 5 degrees. When applying the plaster cast, it is essential to apply the padding tightly around the foot to prevent the foot from sliding upwards later. The less padding material that is used, the better the manipulation will be in the cast. The direction of manipulation in the first cast is supination. The cavus can be corrected after only 1 or 2 casts. It is recommendable to use quick setting plaster. In the case of a calm child, the cast can be applied immediately, extending to the groin. If the child is relatively active, it is recommended to apply the cast in 2 steps. However, a long leg cast should always be used, because otherwise the cast will not keep the increasingly abducted foot in place. Here you can see subination of the foot by lifting the first ray, the lateral fixation of the talus, and avoidance of direct manipulation of the calcaneus. The baby does not appear to be disturbed by this. Here you can see once again the subination position of the foot in the first cast. The plaster cast is applied in the same way to the right foot. Supination by raising the first ray against the fixed talus. By constantly moving both hands, we can avoid pressure sores from developing on the skin, especially over the talus. Ultimately, all toes are freed from the cast. A final look at the cast shows the supination position of the feet. One week later, the cast is removed from both legs. It is recommendable to use a plaster cast breaker to remove the cast. This avoids traumatizing the child with a loud cast saw. The saw also increases the risk of accidentally injuring the skin due to the thin padding. After the first cast, we can already see a clear correction of the baby's feet. Again, both feet are assessed and classified. The cavus is corrected. Midfoot and hindfoot form a plane on the bottom of the foot. We see a clear correction of the adductors and an improved range of motion against the talus. The equinus is now reduced to neutral position. The right side too shows improvement in the manipulability of the navicular, moving away from the medial malleolus. In the same way, the cotton padding is applied very closely to the foot and more loosely in the calf region. For demonstration purposes, we will see now the application of the short leg cast first, which will then be extended to a long leg cast. A slight abduction of the foot can already be seen. The plaster cast fixes the knee in 90 degrees of flexion and the foot in about 10 degrees of abduction. You can already see the future correction of the equinus. The cast is applied in the same way on the left side. The supination component during manipulation is visibly reduced now. The foot is increasingly manipulated into abduction. After another week, the casts are removed. You can notice excellent correction results, with both feet increasingly abductable, now reaching about 30 degrees. Dorsal extension has also improved further. The adductus is corrected. The distance between medial malleolus and navicular has increased further. The heel pad is soft with a high calcaneal inclination. The other side shows similar results. We can see the progressing abduction on the third cast, which has now reached approximately 30 degrees on both sides. About 5 casting sessions are usually required to obtain correction of the deformity. 90% of the cases then require a percutaneous tenotomy of the Achilles tendon. We are pleased to take note that the correction in this baby is excellent after only 3 casts. A percutaneous tenotomy of the Achilles tendon is indicated due to the lack of dorsal extension. Tenotomy can be performed at the hospital on an outpatient basis. First of all, an Emler plaster is applied in the area where the tenotomy is going to be performed. The plaster is left for 15 minutes, then the area is disinfected and the percutaneous tenotomy of the Achilles tendon is performed. For the tenotomy, insert a number 11 scalpel medially from the palpable tendon. Then underrun the tendon and perform a complete tenotomy. The tiny incision site can easily be closed with 2 sterile strips. Then the last plaster cast is applied in the maximum correct position. This is usually where abduction reaches 60 to 70 degrees and the dorsal extension of the foot about 20 degrees. 3 weeks later, you will witness a very satisfying dorsal extension in both feet. The foot abduction brace is applied immediately. The viewing window on the underside aids in adjusting the abduction angle. The affected foot is usually fixed at 70 degrees of abduction. The healthy foot is fixed at 40 degrees. The dorsal extension can be adjusted as well. To avoid any loosening, we recommend using Loctite during the first adjustment by the orthopedic technician. The heel-to-heel distance should match the shoulder width. You then adjust it individually by using the screws in the central plate. When putting on the sandals, which have been specifically designed for clubfoot treatment, you must pay attention to the correct position of the heel. It can be ensured by tightly fastening the middle strap. Once the patient is wearing the shoe, you can check the position of the heel through the window on the internal side of the shoe. The proximal and distal straps, on the other hand, do not need to be as tight. After having put on both shoes, you can connect the shoes to the AlphaFlex brace via the click system. It is just as easy to remove the shoes from the brace. The AlphaFlex brace is intended to maintain the correction achieved up until this point. In the first 3 months, the brace must be worn at least 23 hours a day. Subsequently, the amount of time that it is worn can be reduced to 12 to 14 hours per day. There is sufficient evidence indicating that the degree of parent compliance is a major factor in the incidence of recurrence. The parents are therefore encouraged to strictly comply with the brace protocol. Follow-up treatment using a short or long leg orthosis is explicitly not recommended for treatment based on the Ponseti principle. Here we see Morris, who was born with bilateral club feet. Morris is now 3 years old and shows a nearly unlimited range of motion in the ankle after completing.
Dr. Ahmed,
ايوه يا فندم.
في any problems في الفيديو؟
لا خالص، هو الفيديو التاني دقيقة واحدة هيشتغل دلوقتي.
Okay.
Plantigrade. When walking, we can observe that both of his feet roll from heel to toe as they should for his age. The excellent dorsal extension allows the child to easily crouch down. Standing on his tiptoes is no problem. Moritz's overall mobility corresponds to his age group. Climbing up tables and chairs presents no difficulty either. The prescribed Alpha Flex brace is worn without any problems. If it is worn during waking hours, such as in the morning shortly after getting up, it does not present any real obstacle to the child's playing.
خلاص كده يا فندم تمام.
Okay. Thank you, Dr. Ahmed Sheikh. At the end of this very fruitful scientific night, I would like to thank all our guest speakers, special thanks to Professor Khamis Eldeeb, Professor Gamal Hosny, Professor Mazen Samir, Professor Hisham Elghany, Professor Hassan Elbarbary, and Professor Tarek Hassan for this very fruitful scientific night. Now, by finishing the Talipes Day, meet the experts from A to Z, we come to the end of the first section of Banha online orthopedic review course, which is the orthopedic section. It's a great moment in my life. بعد 5 شهور من التجهيز والتحضير والتعب والسهر، أخيرا بنأتي لنهاية الكورس، وهنبدأ إن شاء الله مع حضراتكم I'm sorry. It's a great moment in my life. هنبدأ إن شاء الله مع حضراتكم الجزء الثاني من الكورس يوم الأربعاء, the official opening of the second part of the course, the trauma section, with many surprises. It will be a very fruitful course containing many national and international guest speakers from all Egyptian universities, from Banha University, from overseas universities in UK, in USA, in Canada, from Ireland, from Germany, from Italy, from Tunisia, from United Arab Emirates, from India. The official opening will be on Wednesday. There will be many guest speakers in this night. We will start with Professor, my talk with the opening of this course, and then Professor Adel Adawi, the former Minister of Health and Population. Professor Gamal Hosny will have a talk. Professor Assam Sharif from Asyut, Professor Sufyan Al-Kallal from Tunisia, and Professor Zohair Nawaz from UK. Inshallah, see you on the official opening of trauma course on Wednesday, inshallah. Thank you so much and have a very good evening. Thank you so much. شكرا أستاذنا دكتور خميس، شكرا أستاذنا دكتور حسن بيه، شكرا أستاذنا دكتور مازن سمير، شكرا أخي أستاذ دكتور أحمد علام، وشكر خاص جدا لأخي الحبيب أستاذ دكتور أحمد الشيخ اللي قاعد معايا كل يوم 5 أشهر سهران معانا كل يوم arranging كل المحاضرات ونعمل الاتصالات مع الناشونال والانترناشونال سبيكرز لحد ما النجاح ده اتحقق من فضل الله سبحانه وتعالى. Thank you so much وإن شاء الله نراكم على خير أساتذتنا الأفاضل. Thank you so much. شكرا لكم.
شكرا لكم جميعا. شكرا. مع السلامة.
شكرا.
مع السلامة.